was talking, but later she couldn't talk again. So we have to start managing her for a lot of my job for almost a year to take care of her. It wasn't easy for me. When she left, picking up the pieces of my life was not too easy. But even when she asked me to come and give this the experience, I wasn't too comfortable because it's still very, very fresh. But she said I can do it. And I said, okay, I will try. So finally she gave up. But I really want to please beg everybody here. I think there should be more awareness. Most people don't know about this sickle cell thing. Even when you try to tell them, they don't understand what you are saying. Even your family members, they don't see the reason why you are in the hospital, in and out of the hospital all the time. When you try to explain, it's like, oh, you like going to the hospital too much. And there's nothing you can do. But I think the greatest thing is we should try and create awareness so that people will know and understand what we're passing through. I really went through a lot last year. It wasn't too easy financially, otherwise, every other thing emotionally. And then losing my close confidence. If I don't want to forget anything, I always confide in her. I say, please remind me of this. And she reminds me, she's very bold, or she was very, very bold. She talks a lot. And there's nothing you tell her that she forgets. It's a painful experience. But there's nothing I can do. And thank you.
Much for sharing with us, and we appreciate the strength and the courage that is taking you to share Zita's experience. There is something that you do not know or understand. At some point, both Auntie Emma and I think even Auntie Dinah, we had that discussion. We're like, if Zita is going to die, we think God should call her home, because at some point, all three of we all got tired, including the mother, because she was suffering so much, going through so much pain, and we think everyone deserves to live with dignity. So if we can go back to the slides, it's a very beautiful, lovely girl who loves to tease and all that. Can we go back the previous slides? And Isita needed various blood transfusions, like the mother said, and eventually these were her final days. She had to feed through an NG tube, even getting the food to feed her. It's very expensive. the protein and everything, the diapers, and she developed bed sores. So aside paying for medications for sickle cell disease, you are paying for complications of sickle cell disease, you are paying for gauze and cotton wool and everything that are diapers that are needed to dress the bed sores from the stroke where she's been lying in bed for so long, the diapers because she can't get up to use the washroom. Her whole life was turned upside down. What you do not know too is that Auntie Emma is an accountant, but because of sickle cell disease, she had to stop all of this and start selling foods in the market. And it's even difficult to now go into the room where she lived with Zita because that memory always comes. But because sickle cell has impacted her so much financially, she can't move out. And these are some of the realities on ground and the support that we need from society, because at some point her family was tired. People get tired when there is always a call about funding and one problem after the other. And that's why we need sustainable support for sickle cell disease. It can't be done by non-profit organizations, only the government and corporate Ghana. Everyone needs to get involved. So thank you so much for sharing your story with us. Now, because of time, we'll move to Miss Dinah Juma Bedu to help us understand what such a journey looks like from the front line of pediatric care. We would want you to tell us, first of all, why early diagnosis and regular care is so important in sickle cell disease, and what gaps in care can lead to severe complications, hospitalizations, and even death in affected children.
All right, thank you. All right, thank you. And just to start from a point where one of the initial speakers said, no child should be disadvantaged because of their geographical location. It is something that's very dear to my heart. If you look at the developed countries, their incidence or prevalence of sickle cell is so negligible. Sad that sometimes when our patients even move to certain parts of the world, it's difficult to even get somebody or a clinician who even has an experience with sickle cell disease to take care of them. That tells you how fewer numbers they have. But with a country where 2 out of every 100 children born have sickle cell disease, we have no excuse. 15 to 18,000 children born every year. And most clinicians here will agree with me that the number that we see in the hospital is just the tip of the iceberg. So where are these children? They are with us. Some have even died without us even know they have sickle cell disease. Early screening is very, very important, and there's so much evidence that has buttressed these points. A lot of the researchers have come from the countries where the disease burden is negligible. So what about us who have the disease burden? What are we doing? Unfortunately, newborn screening is not nationwide. Last year, 2025, marked 30 years of newborn screening for sickle cell in Ghana. Professor Hine Frimpong, God bless his soul. And this was under a non-governmental organization sponsorship. That was 30 years ago. And it was only accessible to babies born in Konfanoche and a few satellite hospitals in Ashanti region. So 30 years, that is 1995. So from 1995 to 2017, if I was born in Accra, if I was born in the northern part of Ghana, did I have access to newborn screening? No, but I may have been part of that 2 in the 100. I may be part of that 15,000. But who was diagnosing me? But geographically, because of where I am born, I have no means of being identified that I have sickle cell disease. As until 2017, again, under a non-governmental organization, Kolebu Teaching Hospital started newborn screening. Again, if I was born in Northern Region, Brown Hafo, or where, what is my access to diagnosis? And we are in 2026. I can single-handedly tell you how many centers are screening for sickle cell here. And 90% of them are located in Greater Accra region. Kumasi is no more testing because the funds have ended. So for the last 2 to 3 years or even more, no baby has been screened under that program. So what are we doing to ourselves? It breaks my heart to see that with this disease burden, children have not been diagnosed. CHAI and some organizations have tried to reach deprived areas with simple machines that can help with screening. Maybe the American Society of Hematology, all these people that I'm talking about, they don't offer nationwide because there's a little they can do. They are just trying as much as they can to be able to reach the children. The gap is still so big. And unfortunately for us, the northern part of Ghana is where they have nothing. No access to screening, no access to treatment. So if you find yourself in Accra, at least you can move from one place to the other. The effects of not screening early is so much. Increased deaths. If a child is not screened, 80 to 90% of children who don't get diagnosed and don't get treatment don't live to see their 5th birthdays. That is 80 to 90%. So that is how serious it is. They get complications such as stroke, which can easily be prevented by doing a simple scan, which unfortunately is unavailable in several parts of Ghana. So these children come to us with strokes. A simple penicillin is enough to prevent certain infections that kills them and very prevalent in the first 5 years of their life. But because they are not getting diagnosed, they are not getting access to these preventive measures. And again, they are dying. I'm just going to look at the reverse of the effects of us not screening early. The benefits of screening early is to offer education and genetic counseling. There are a lot of superstitions in our part of the world as to how somebody has sickle cell disease. And I take care of newborns. So a 2-month-old baby comes to you and you tell the mother that the child has sickle cell disease and they look at you and tell you that they reject it in Jesus' name. Because the baby looks so healthy, there's nothing wrong with the baby. So why do you want to tell them that this baby has this sickness and could be very sick in a few months to come? That tells you that they don't even believe that that child is sick. So if we diagnose them early, we're able to offer the education to them, explain to them what they can do. Genetic counseling. Every disease in Ghana comes from the woman's family. Yes. But from the video that we watch, it's from both parents. And parents who appear very healthy, but could be carriers of sickle cell. Again, we're able to screen for some of the complications, such as stroke. Unfortunately, your highest chance of getting a stroke if you have sickle cell is between the ages of 2 to 5 years. So I've had children who are 2 years, who are 3 years, who cannot talk, who are wheelchair bound because of strokes. And these parents had no idea that these children could be sick. We are able to offer them penicillin and also lastly, give them what we call disease-modifying therapies, such as hydroxyurea. Lucky from 2022, the NHIS is covering, and we have close to several children who are on hydroxyurea. What are the gaps that are facing us? There's disparity in care. I've had patients who travel almost 24 hours to access comprehensive care in Kolebu. As far as Liberia, Sierra Leone, they all travel here because they don't get access to certain care. How are we training our healthcare professionals? Does the doctor in the northern region has access to the same training, the same knowledge to be able to manage a child with sickle cell disease? Do they have the equipment? Do they have even the means of referral? Sometimes we have children that need to be referred. They cannot afford transportation. So the gaps exist between a human resource, the equity in even the comprehensive care, to even the basic care that somebody with sickle cell needs. Also with essential things like transfusion. How many people are donating blood? But you'll be amazed that I have children who need to be transfused every 3 weeks, just like Zita's mother said. And that is the way to prevent strokes. So if we are not getting this blood, what do you think will happen to us? So it is a call for us to rise up and ensure that we screen these babies early, get them to comprehensive care to ensure that we reduce the mortality and morbidity that is associated with sickle cell disease. Thank you.
Thank you very much. That was an in-depth explanation. Now it's becoming clear. We are really getting to know the situation on the ground. We shall turn our attention quickly to Dr. Enam Bankers. Dr. Enam Bankers. So you are a sickle cell warrior. You are an advocate and a hematologist, and you understand this condition not only from your work as a doctor, but also through your body and advocacy journey. We want to know, based on what we've heard so far, your lived experience as a person living with the sickle cell disease, your work as a hematologist, and recent happenings. What do these realities tell us about the seriousness and unpredictability of sickle cell disease? We also want you to enlighten us. What do these things reveal about the gaps in adult care and the urgent need for stronger research, innovation, and creative options, especially in Africa?
Thank you very much, and thanks for the introduction you gave me earlier on. Many of you know me as the founder of Sickle Life, but then today we mentioned Heal, and I'm a little pained that today I'm here alone because Heal is actually a merger between Sickle Life that you know me for and the Sickle Cell Awareness Initiative, SKY, that was founded by Ms. Nanesi Duka. Some of you may know her. And we talk about the unpredictability of sickle cell. And for me, the reason why today I bear a lot of pain is that last year, after working together for several years, we had decided to merge as one entity. But then sickle cell being so unpredictable, we lost her about 10 days to the launch. And this was work that was 3 years in the making. And so for me, the reality of the unpredictability of sickle cell is very tangible. It goes beyond me being a doctor or hearing from my people who reach out to me as an advocate, but as a person living with sickle cell disease myself, and somebody who has a lot of people who live with sickle cell disease around me, I see a lot of how sickle cell affects the quality of life of people and how things change very quickly and how even though we have all the knowledge, we are not able to make a difference and we keep losing our people. And so, yes, I'm sure many of you have heard on the wards that people will say, as for these sickle cell patients, they'll be lying there looking okay. Then the next minute, they are rushing to the ICU or they are rushing to, or they've passed away. And much as that's a common trope, it's something we hear, I don't think that the seriousness that it deserves has been attached to it. And I'll use myself as an example. I think it was 2024 December, I was admitted to the emergency of my own facility. And what had happened is that I attend the sickle cell clinic at Kolebu. And so for about 5 days during the week, I had been going in and getting painkillers and hydration and all of that. But then it was Friday night, I started having chest pain. And immediately I called my doctor and it's like, emergency. So I went there. And when I went there, I called my colleague hematologist, and then my senior resident or my chief resident literally left her daughter that she was picking from school and came to attend to me, wrote the notes, did everything, standard of care. And then when it was time to dispense the medication, the nurse said he will not administer my anticoagulant. You ask why? Because there was a technical issue with the computerized system. And so even though I'm a health worker in that facility and I could open my own computerized system and show the doctor's notes that said administer therapeutic doses of anticoagulant, I had to literally fight to be given anticoagulant, to the point where I called one of my senior colleagues and I was like, if it's hydration, I have some at home. If it's analgesia, I have some. I come here because we are suspecting acute chest syndrome, which makes sense because I've just had 5 days of acute pain. And you decide that a key part of the therapy is going to be withheld because there are technical issues. So yes, we can say sickle cell is unpredictable and all of that. People have heard about this condition. They know about it in theory. But when it comes down to it, they'll tell you that sickle cell patients change suddenly. Meanwhile, the tangible things that need to be done to ensure that those changes don't happen are not being done. So that's a very, very important thing that I think that we should all go with. Yeah, we may change suddenly. Things may be unpredictable, but for a lot of the things that are said to be unpredictable, right now there's data. Somebody has probably done a study to prove that this thing that you are thinking is unpredictable is very much predictable, and this is what you should do. When it comes to the gaps in management of adult patients, I think that, so we basically inherit the challenges that PDX has, so these kids are not being diagnosed, right? And so for many people, their first diagnosis is with a complication, right? And so much as we do a lot of acute pain management and yemano drip kakra, yemano painkiller, even with that, they'll be giving the medication in aliquots because they are afraid of the medicine, because they think you get addicted and all of that. We realize that on the adult side, the transition from pedics to adults is quite challenging because especially in the adolescence period, you were put on hydroxyurea as a baby and mommy was giving it to you. Now you are in senior high school and you're supposed to take some medicine every day and your colleagues are not taking it. It's making your nails dark. It's making you look dark. So for many of these people, that transition is a problem. We don't have a real organized system for our transition from the pediatrics to adults care. And so then at the teenage age, we end up losing a number of our people, and it's also the fact that sometimes when they go to school, the schools are not empathetic or sympathetic. So yes, the child has sickle cell, please exempt them from these activities. And then it's like, why? You don't want to work? Why are you being lazy? So yes, there's information. People have heard about sickle cell disease, but practicalizing it becomes an issue. Also to state that with these late diagnoses, with the lack of comprehensive care, with the fact that things are being done in silos by small NGOs in their own corners, we end up with a situation where a lot of our adult patients have complications, right? So there are people who have renal failure, end-stage renal failure. They need dialysis because of sickle cell disease. As an adult with sickle cell, if you are going for dialysis 3 times a week, how are you going to work to sustain that? People have avascular necrosis, and I know somebody from my advocacy work who was in corporate Ghana, right? He used to pick Trotsky to work, but with the AVN diagnosis, he had to resign. He had to quit because entering a trotro is a problem. The pain in the hip is such that just to raise his leg to enter that trotro is a problem. I know a chef, avascular necrosis, standing for hours. She has to stop working because she just can't stand to do that work, you know. And these are like some of the complications that often we think about sickle cell, we think about pain, but then when we are not having national and comprehensive care, what ends up happening is that we'll see people later with complications. Another example, there's this young man that we help with at Sickle Life. He has a chronic leg ulcer. But because of this difficulties and the situations in life, he basically has to do security work, which means he wears boots every day, constricting the blood supply to his legs even further, and he has to stand. And so this leg ulcer would already not heal quickly. But now, due to external factors, the ulcer is persistent. You know, so I could go on and on and on about the long-term effects of us not having a national and comprehensive outlook on how we manage things related to sickle cell disease. But then the bottom line is this: everything we do ought to be patient-centered. It ought to be patient-focused. We need to think about the patients and their caregivers and how it's affecting them. And then it will help us in even determining our priority areas, where our money should go, what we should be doing. And then we'll be able to ensure that we can utilize research that abounds elsewhere and even do some locally and make tangible changes to ensure that we are improving the health and well-being of people living with sickle cell disease. We can have policies on paper, we can talk about things, but then if there's no national format to it, or people are doing it in silos, then in the end, it's in the books, but on the ground, on the ward, when the patient comes, the nurse will decide not to give them anticoagulants. Thank you.
Thank you very much. DCNU, Jocelyn Dunyo. Am I right? Thank you. So, you are from Ghana Institute of Clinical Genetics, one of the oldest and largest adult sickle cell clinics in Ghana. Help us to know or to understand the burden that your clinic carries, including the number of patients you see compared with available wards, staff, equipment, and resources. We also want to know what this tells us about the urgent gaps when it comes to adult sickle cell care in Ghana.
Thank you. Sickle cell, Ghana Institute of Clinical Genetics is 52 years. This year has been 52 years. And it's a day clinic. 8 in the morning and close at 3 p.m. We have 2 wards with 13 beds. 13 beds in the 2 wards. So when the patient comes, those who have crisis or those who are not well, we detain them for a short time and discharge them. So those who need further detention or admission, we have to send them to other hospitals. And in Ghana, you can understand us. I remember one day we even called you. We will call all the hospitals, and sometimes to get a bed is not easy. In a year, we take care of about 3,000 individuals and 10,000 visits to the clinic. So in a week or daily, we take about 40 patients a week. And 1/3 of this 40 is detained as those who comes in with crisis. And we have only 13 beds. So it's not an easy issue. When we talk of equipment, Ghana Institute of Clinical Genetics is 50. We only run 4 blood counts. Urine RE, the chemistries, we have machine, but not yet. And all other equipment, we don't have it. We don't have enough that we use. So at the end of the day, the patient comes and we write the labs for them to do them outside. Yeah. So we need help a lot. The patient needs a lot of support in Ghana Institute of Clinical Genetics. Gaps, they need financial assistance. Very important because the patients are on health insurance. But when we talk of health insurance, it covers only the essential drugs. So when they get the essential drugs, the other things they have to pay. And as Dr. Enam said, some has a lot of complications that even working is a problem. So please, I think they should put sickle cell patient on insurance for all other labs and medications, please, so that they can live very well. Because when they come, some of them, without the institute supporting them, they can't even buy their, I would say, folic acid. So with financial support, they really need it. Equipment and infrastructure. I think it's a high time we have to get our own 24-hour service. Because they will come and we will send them somewhere that we don't even know what medication or what treatment they are going to do or they are going to offer them. So I think it's a high time that we get all the equipment and the infrastructures that they have to benefit from. And this one, I think we have to extend it to all the 6 regions in Ghana so that people will not travel from the north to Kolebu for sickle cell management. Please. Please, we have to look at all this. Even if it's in the regional basis, it will be better than only Konfuanoche and Kolebu that they get all this care. Again, the human resource or our health centers or wherever everybody take care or medical attention, I think they should train them regularly on management of sickle cell disease. Because some will go somewhere and they will come to Kolebu, you see that they are coming with a whole lot of complications. So I think we should have regular training for staffs so that when sickle cell patient everywhere or that everybody takes care, we should manage sickle cell patients in those hospitals or health centers. Thank you.
Thank you so much. Before we move to Stephen Akomba, I wanted to add to what you said. So, in fact, I once received a call. We had something really urgent to do at ISCC, and some of you might remember Shadrach. He was on the panel last year, and some of ISCC team members work at the institute. So they called me. They said, "Mary, you need to come here right now. Shadrach is not well. Something bad is happening." I said, "What is it?" They said, "We can't tell you on phone." So what had actually happened was Shadrach had 3 cardiac arrests at GICD, and he was resuscitated each time. And there was no bed. We called for like he had to, someone who has had cardiac arrest cannot be discharged home, and he had to be taken elsewhere. The hematologist went to the main Kolebu trying to get a bed, Kolebu Polyclinic, no bed, to the extent that we called ambulance was not coming, and this guy needs ICU care, literally, right? And then eventually, what we had to do was put him in a wheelchair, someone who is so lethargic, not well, and put him into the car of a nurse and drive to one of the, I think, Mamprobi Polyclinic. That wasn't the only thing. The doctor had to speak to the hematologist has to speak to the doctor how he should be managed in terms of medications and all that. And even recently, one midnight, he called me because the doctor didn't want to give him morphine. The doctor said he has to follow the WHO ladder of pain management. So he's starting from paracetamol. And then he said the next thing he's going to give him is tramadol. So we really need that education of our healthcare professionals. And GICG is actually the oldest and biggest sickle cell clinic in Ghana. So imagine they're facing these challenges, how much more other areas in Ghana. So the gap is really huge. And we are now going to hear from someone who is living in rural Ghana, the northern region. What is the issue on ground, Stephen Ankoba? Can you highlight, can you tell us, can you paint a picture of what it takes for patients and families in Saboba to assess sickle cell screening, diagnosis, essential medicines, and follow-up care? And what are the biggest challenges they face? Because of time, let's please keep the answer quite concise.
Madam, appeal for the extension of the services, and you mentioned 6 regions. Did you mean 6 or you wanted to say 16 regions? I want clarification.
I said 16 regions.
But you said 6. So I just wanted to be clear because as chair, I'm taking notes. I don't know. So if it was slip, correct. Thank you.
Our chair is really active. Thank you so much, Dr. Hafiz, because he must take it to the Ministry of Health for action. So, Stephen, over to you.
Okay, thank you so much. The picture looks very dark in the underserved communities like Saboba. I work at the health center in Saboba town. And Saboba is a very remote area with a very bad road network, surrounded by water bodies, with scattered kind of settlement, such that one community can be as far as 40 kilometers from Saboba town. And in some of these communities, you have to cross River Oti with a canoe before you come to Saboba town to access healthcare. Now, in Saboba town, we have a CHAC facility, some have called hospital, which is serving as a district hospital. They have only 2 doctors, an obs and gynec specialist and a pediatrician. The other facilities around are health centers and KIPS compounds. And so imagine a child having crisis already who has to move all the way from a community, come to the riverbank, wait for the canoe driver to come, take you across the river. You have to take a motorbike or tricycle to the hospital or the health center. Then when you get to the hospital or the health center, we have only 2 doctors. There is no structured system to care for people living with sickle cell disease, whether you are in crisis or not. And with a population of 113,000 with 2 doctors, you can imagine the burden on the doctors. They are always overwhelmed. Either they are in a theater or in a ward. So how would they divide themselves into pieces to take care of people living with sickle cell disease when they are in crisis? As if that is not enough. In the hospitals, sometimes, whether hospital or where I work, health center, sometimes we, as basic as it is, you have to prescribe for a patient to go and buy folic acid from somewhere to come. Just tap folic acid. Sometimes penicillin V, not even sometimes. For 3 years now, I have personally made sure that during drugs requisition, I will make sure that, have you added folic acid? They say yes. Have you added penicillin V? They say no. I will say add it. They will add the requisition, but when it comes, nothing comes. You don't have penicillin V tablet. The hospital is the same. Not even talk of hydroxyurea. So if you want to if there is a critical case, you want to refer the case to the nearest referral center, which is Tamaris Teaching Hospital, is over 150 kilometers. There is no public ambulance service. The family cannot afford the services of the private ambulance. How will you transport a child who is already in crisis? Look at crossing river with canoe. Come to town, you have to refer to TTH. Then they can't go because of money. They can't go. And so, against this background, 3 years ago, as a nurse working in a ward, even at the health center, I felt that let me try to do something as little as I can to help somebody. So I started with a sickle cell clinic, or a project. I call it Empower for Survivor. Then I was able to gather people. I've registered, as at now, over 100 people living with sickle cell disease. I've registered, they are in the register. So what we've been doing for the past 3 years is to call for clinical meetings. They come, give the education on how they even have to self-manage themselves. Some don't even know that the extreme weather conditions is a trigger factor to the crisis. Some don't know that exposure to infections like malaria can trigger the pain. Some don't know. I mean, it's a lot. Where will they hear if there are no specialists to talk to them? So with the little resources we can get at the health center, we call them for clinical meetings, and we have registered them. The data is there. And if you want to diagnose by, taking samples to do, for example, HB electrophoresis to get to know the type, you have to take the sample, parcel it in cold chain, and take it to TTH. They will do the test over there and send it back to you at a fee. If you want to try the outside, the private labs, they charge too much. The clients cannot pay. So because of all these challenges, the clients, they resort to the traditional medicine practitioners. After all, they promise that they have cure for it. So if I cannot come to the hospital and get the standard care I need and get what the evidence says we should do, and somebody outside says he has a cure, why not go and try? So they go there. And the practices over there is an eyesore. Have a razor blade, cut every part of the body. And as the skin is bleeding, they have some herbal preparation they will apply on the skin and wrap it with a white linen. When they wrap it with a white linen, they keep the patient indoors for 7 good days. You eat and drink indoors. On the 7th day, they bring you out and unwrap the white linen, expecting to see live maggot moving on the white linen. And they do see. So the movement of the maggot, the live maggot, literally means that the disease has come out of the body. And as we speak, more than 80% of the people I have registered have gone through these procedures. Some twice, some thrice, yet nothing has changed. So the challenges are too much. But when I started last 3 years ago, all my aim was to do what I can and seek for support from everywhere so that anyone who voluntarily comes to help will do. So I've been to the basic schools to create awareness. I've been to secondary school to create awareness. I've called for several meetings, some stakeholders meeting. I've had a chance to make presentations during end of year presentations, sub-district or district-wide meetings. I've done that. And I'm glad this opportunity here for me today. I'm part to talk about it. And I know that something good will come out of it. During the short break, I personally went and greeted Dr. Afis because I heard him spoke the Banley. So I said, this man must do Tamale. So I went and greeted him. And then he said, where are you coming from? I said, Tamale, precisely Saboba. So I'm emphasizing that Saboba, we need help. So thank you. I don't have enough time.
Thank you so much for that touching and heart-wrenching submission. And we know our chair is taking notes, and he's definitely going to present it to the Ministry of Health. Because of time, I'd like to end this first panel with one clear advocacy ask. Just 1 minute or less than 1 minute. If you all had the opportunity, imagine President Mahama is sitting here, the Ministry of Health is already here, Ghana Health Service, NHIA is also here. Some donors are here, philanthropists. What one urgent commitment should they make after today to improve the lives of Ghanaians affected by sickle cell disease? We'll start with Auntie Emma.
Thank you. They should try and support the clinics and then NGOs, and mostly I like, awareness. I still say it every day. Most people are not aware of the sickle cell. So the government should really put in place awareness for people to know right from the big, that's starting from where you're going to get married and all those things. If awareness is there, you have to go for tests before getting married. And so I think awareness is one of the greatest, and then they should be able to finance the sickle cell clinic to help the parents and the patients. Thank you.
One sentence, please.
Make newborn screening for sickle cell nationwide. There are very inexpensive point of care machines that you don't need electricity. From what Steven shared, we need, and it costs just $400. One V8. Make the calculation. How many machines one V8 can buy so that children can be identified? And secondly, make hydroxyurea, a life-saving medication, accessible to all patients irrespective of their geographical location. Thank you.
Thank you. So for me, I don't know whether this is asking too much or wishful thinking, but I believe that it's time for sickle cell to have a national program. I know there's an HIV, there's TB, there's malaria, there's non-communicable disease program, but can sickle cell have a national program so that everything is coordinated? The things we are doing don't depend on the individual brilliance of people or their personal experience or having to quit their jobs to make sure that their NGO can work. Sorry, more than 1 minute, but I'll just have to plug in that, for example, today, you might have seen more than 10 different World Sickle Cell Day events, right? Even for STEM Hill, we have an event in like a few minutes, but then a national program so that then all of us with our different experiences and funding and links and everything work together as one. A lot has been done, but there have been a lot of pilot projects, 30 years of newborn screening, and we are not national. If it was under a program, it was coordinated, then we know that we can go to Tamale and they'll get the same thing. The quality of care I get at the sickle cell clinic in Kolebu will be the same quality of care that his patients will get where he is. Thank you.
Financial assistance. I think sickle cell patients should be able to use their health insurance for all other lab investigations and drugs that they need to take. Again, Ghana Institute of Clinical Genetics want to run 24-hour service. So if the government will support us, we will be happy to do it. Our service, yes. Service. Okay, yes. So we too, we want 24-hour service. Yeah. Thank you.
Thank you. I want to see a team of specialists, doctors, nurses in a well-equipped mobile van, moving from one underserved district to another, delivering evidence-based care to everyone living with sickle cell disease at affordable cost. Thank you.
Very soon, you'll be seeing mobile clinics moving around. At the launch of the free primary health care, they were all ready. In fact, some of them were working for them to be delivered, particularly to the hard-to-reach areas, and that includes your area. So these mobile clinics are equipped with solar panel. There's what we call it, a generator in case you don't have lights, and they have even tents when they come where they can display, and there will be a nurse, there will be a laboratory technician, so that the screening that we have mentioned as part of the free primary health care, all these things will be part of it. So that is a good news for you. Very soon it will come up. Thank you.
Thank you, sir.
So from all that they've submitted, I am thinking as an educationist, I'm thinking if, since the sickle cell patients need special attention, can the curriculum in the nursing trainings be adjusted so that just as we have specialized nurses for gynae, for pedics, we have nurses specializing in that area so that they will know what to do. Some won't wait to go through the ladder or the format for giving painkillers. So when they get patients, they know exactly what they are doing. So if this policy can be worked on, it can help. Thank you.
Thank you all for coming to share your experiences, your expertise, and helping us understand sickle cell disease better and appreciate the gaps and situation on ground. There is some wonderful surprise for some of us on this panel by well-meaning Ghanaian corporate organizations. But before we get to that, I would want us to move to the second part of this panel discussion, which is going to be led by our faith-based organizations, community platforms, and also thank you so much, our speakers. We are grateful. A quick photo, please, with our panelists. So we would dive right into the part two, the part B of this panel discussion, and would like to invite Simona Ephraim Foundation, Mr. Larry, who is a CEO of Simona Ephraim Foundation, to the stage. followed by Ahmed Sharif Kanvila Yusuf, who is a genetic counselor at Kolebu Teaching Hospital. Shall we give them a round of applause as they come up stage? Is Larry around? Okay. Let's also have Reverend Dr. E.A.K. Annie from the Christian Council of Ghana, if he's here with us. We'd also like to invite Dr. Jennifer Daniel Visca from Mamobi General Hospital. She's a representative of the National Chief Imam, the Office of the National Chief Imam. Let's give her a round of applause. Last but not the least, we shall invite Dr. Owusu Ansa Daniel, who is a treasurer of the Ghana Federation of Traditional Medicine Practitioners Association, GAFTRAM for short. Let's give him a round of applause as he comes. Or should I speak? I'm looking for the question. Thank you so much for making the time to join us today, regardless of your busy schedules, and helping us advance conversations around sickle cell disease. Like we shared earlier, we do not want this to be a talk show. Our chairperson is really taking notes, and we want to make sure that a year from now, what would the Christian Council of Ghana have done? What would the Office of the National Chief Imam have done? What would GAFTRAM do? What will Simona Foundation do? What will you do as a genetic counselor to reduce the burden of sickle cell disease in Ghana? Because we believe that when we all come together and work on this issue, there's going to be so much tangible change in Ghana. So thank you once again. We would like to dive into this panel session, and I'd like to start with Simona and Frame Foundation. I know we've heard from Auntie Emma, we've heard from Dr. Bankas, but then you are a caregiver and you have a son with sickle cell disease. So as a father, looking back on your family's journey, what do you wish your community, faith leaders, schools, and health workers had understood earlier about sickle cell disease, and what support would have made the greatest difference in the life in your family? Thank you.
Thank you. I think with sickle cell, something we should all know, it is not spiritual. When my son was diagnosed at the hospital, I asked, what do I do now? Where do I go? How do I start? The nurses said, oh, do fear, go and pray. And to me, I felt that was the dumbest thing, because we are all Christians. At that point, that was the least thing I needed. I needed to hear something that would calm me, let me know there's hope. Because any other person who hears of sickle cell tells you, oh, with this disease, just think of something else. No need of you to push in money. So if we as a nation, as a community, can have a system where there is counseling for caregivers, counseling for sickle cell warriors, it will go a long way. At our foundation, we have started doing the counseling, and we've come into contact with some of the sickle cell warriors who will tell you the truth that at a point in time they have thought of committing suicide, especially when the stigma is so much and people do not even consider them worthy. I met one guy at a program and I was seated next to him. I didn't know he had sickle cell, but he didn't even feel comfortable me being next to him. What he said was, oh yeah, Penny, so why should I sit next to you? I said, we are all human. We are the same. So we should help them feel comfortable in their skin. It's not just money that they need. At times, they need a support, word of advice to push them through. And this can be done through churches, so many institutions. When you know that in your institution, be it workplace, school, that person has sickle cell, give him an extra hand. We go around to educate teachers, especially, how to handle children with sickle cell because their span of having attention is very limited. After every 20 minutes, let him walk around, go for water, come back and sit. You will have his attention. But many teachers do not know.
So much, Mr. Larry, for sharing this with us. And I think it brings us to genetic counseling, because what the nurse should have actually directed you to a genetic counselor, or the nurse should have been trained in genetic counseling so that they teach you about sickle cell disease, how to manage it, and help your son thrive. So we'll move right to Ahmed. Yes, Ahmed. And Ahmed, we what should every young person, couple and family in Ghana understand about sickle cell inheritance and reproductive risks? I think we saw the video. And how can we promote voluntary testing and informed decision making without stigma, coercion, or telling people whom they can or cannot marry? I know some of us will not agree to this, but we'll hear from the genetic counselor. Yes.
Right. I think the most important thing every couple and young people in Ghana should know is that sickle cell is inherited, which means that when a child gets the sickle cell gene from either the mother or the father, that child can have the sickle cell disease. That's important for them to know because it would then influence the kind of reproductive choices they are making. Now, even when they do know that, it's also important that if you know your genotype, you still need to speak to a genetic counselor because you need to know what those reproductive risks are. Because I personally have had patients that both father and mother were carriers, then they are told that the chances of them having a child that would be affected is 25%. Chances of you having a child that will be a carrier is 50%, and chances of you having an unaffected child is 25%. And they go into marriage assuming that this would influence the sequence of the children they would have. So if the first child is not sickle cell, they believe that then the second child would be sickle cell. So it's important for us to also address this misconception so that people know that this recurrence risk is for every pregnancy and not just the first time you have the child, the second time you have the child, the risks are going to be different. I also think in a way to sort of prevent stigma or reduce the stigma, we should more focus on community engagements and school-based education. So in my capacity, I have collaborated with other warriors where we go to schools in the Greater Accra region to educate children in primary schools about sickle cell. Now, we are targeting the children because if children are able to get that sort of understanding, we are hoping they grow up to become individuals that will be more empathetic and more open to embracing people of diverse backgrounds and people with different conditions. And we've seen that this has gone a long way to improve even the way they relate with their colleagues in schools. Because for most of the schools we've been to in Accra Central, we go back to the school and you hear even the children that have sickle cell tell you that because you did this education, my colleagues now understand exactly what is wrong with me and they approach me more differently. For genetic counseling and us not telling people who they can and cannot marry, I think the most important thing is for us to provide accurate information that empowers these people to take decisions that work for them or align with their values and their circumstances. I think one other thing we also have to keep in mind is that the ultimate goal of knowing your genotype is supposed to empower you to be able to make choices that work for you and not to label you. And also, knowing your genotype should also not restrict your choices, but also expand those choices, because now you know the options that are available for you in terms of reproductive options. Thank you.
Thank you very much. This one is a joint question to the Christian Council of Ghana rep, the National Chief Imams rep, and the GAFTRAM rep. So we have heard the awareness, and what happens with a crisis, with marital choices, childbirth, and families forced to handle all these issues. Our question is that, what unique role can your platform play in helping Ghana move from late sickle cell disease awareness and missed opportunities to early education, informed decision making, stigma reduction, and timely referral? And what existing structures within your network could be mobilized immediately to support this effort?
Thank you very much. But before I answer the question, I want to bring two issues to the fore for us to appreciate the kind of problem we have as a Christian community. The first thing is that many of us are first generational Christians. When I say first generational Christian, I mean we were born by parents who were Christians. But in a community where our foundation is African traditional religion, whether you like it or not, you may be practicing certain things within your Christian faith, which its origin is not Christian. That is why in the earlier presentations, we heard one of the speakers telling us when a diagnosis was made in the hospital about a child, a 2-month-old baby, the parent of the child disbanked it by saying, "God forbid, I reject it in Jesus' name." We are, as Africans, we are more religious than any other thing. So in New Testament studies, there's something we call syncretism, where you try to blend another culture to another culture, one belief to another belief. And by so doing, we believe strongly that from where our parents started from, they believe that sickle cells is either a curse or punishment by the gods. So our belief as Christians is that we believe in divine causation. Anything that happens to us, then it must be happening because of the divinity. And so we hardly apply scientific analysis to the things that happens to us. That is why sickle cell disease becomes so serious and dangerous among us, because we do not want to believe that it has been caused by our genotype levels. The second thing that I want to also say is that in African traditional religion, we believe those who are sickle cells, we don't know it as sickle cells, but we know it that when somebody or couple begins to give birth to children and they die, the infant mortality rate going up, then that family is totally cursed, and for that matter should not be accepted in society. Because of that, we have transported those things into Christianity, and it is very, very important that at this stage, in this 21st century, we should be able to come up with specific and strategic role as to how to address this as a church. I want to address the issue by 4 thematic areas that is embedded in the question that is being asked. In the first place, we want to say that the church can give early education by using the pulpit to demystify what sickle cells is all about, so that people will move away from the thinking that sickle cells is a curse or a punishment. If we are able to explain through the pulpit, the reason why I'm saying through the pulpit, people believe in pastors than even God. That is why a pastor can command his whole congregation they should go and eat, and they'll run out of the chapel and go and eat grass. So if the pastor can use the pulpit to explain what sickle cells is all about and make them understand that it's neither a curse or a punishment from the God, but that is scientific, and those who are carriers can be helped to understand themselves better. I think that will be better, and that is what the church can also do. The second thing is to have partners with health specialists. Today being World Sickle Cells Day, churches could also organize seminars and forums where they could invite specialists and people who have experienced sickle cells to actually educate the entire congregation about it. Another partnership is to form a support-based organization within the congregation. For instance, my church, every year in May, we try to mobilize our youth to actually donate blood because of sickle cells, because we know that the sickle cells disease at times also needs some infusion where they go in for blood. And therefore, we make it possible that I call a Boo Teaching Hospital. We have a blood bank specially made for EP Church. And when you go to the bank and mention that you are from EP Church, whether you are a member of the EP Church or not, once you take a note from the EP Church pastor to the bank, blood is for you to use. So we make it a point by giving out blood so that it can be used for people with sickle cells. And then we also want to make it a point these days. When I was getting married 36 years ago, I went through my premarital counseling. Nobody talked to me. The counselor never talked to me about genotype testing or to talk about what sickle cells is all about. I never heard anything like that. But these days, the church is making it a mandatory policy that before you get married, you should be able to go for genotype texting. And if there's a need for you to be referred to a specialist, they do that. Another point that we want to also put across as a church and the church community is to empower union planning, where I just heard from my brother that some Christian pastors, when they are counseling and they realize that one of you is a career and you may impart it on your children, the solution for them is then you can't get married and they'll prevent you from getting married. Instead of them asking you to go to a genotype who will actually lead you into the knowledge of whatever it is and to empower you to be able to take an informed decision. They rather impose a decision on you and ask you. Meanwhile, the people are in love. They are in love. And if they don't want to listen to you, the worst thing they can do is to move out of your church and go and get married somewhere. And when they get married, then they put the entire family in a distressed position. And therefore, pastors could be trained to become genotype counselors. Pastors could refer couples they notice after testing that they have that problem to specialists for them to further counsel them. Finally, I want to also mention that the church, because of the distressed nature of disease, the church can also form a support-based organization in the church where we spend time visiting, empathing, and socializing with people living with the sickle cell disease so that they wouldn't feel different from those who are in the church. We just heard that there are some people who, after noticing the distressed nature, the financial position of the disease, and other issues, they sometimes consider suicide. So that if there's a support-based organization in the Christian church, they will always have to visit, support financially, and probably at times socialize with them to also make them feel important. Thank you.
So much, Reverend Emmanuel King Foley. We're actually behind time, like over an hour behind time. So if you can kindly make our submissions really concise so that our chairperson will also be able to take notes and we can move on to other things on the agenda. So over to you, Dr. Vitsa. Yes. Viska, yes.
Thank you very much for this great on behalf of the On behalf of the Office of the National Chief Imam, here very quickly, the Islamic community of Ghana has different structures, starting from the National Office of the Chief Imam. We have the regional offices, we have our districts, our municipal, down to our community mosques, and where our education in schools, the Makaranta, and then the Islamic school diversify. So some of the existing Islamic structures that are ready for immediate mobilization that we have currently are our mosques, the Islamic school, our premarital counseling units, the women and family counseling organizations and associations that we have within our Muslims community, and then the youth association, welfare, and then the outreach community. These are already in existing, but what we'll do currently as part of the Muslim community in helping combat, prevent, and advance the care and welfare given to the sickle cell affected people is to strengthen this existing platforms to carry out this issue. The ways that we'll do in 1 year, we hope to achieve that in our communities. The first thing we'll do in order to carry out the community awareness and education is that monthly, which we are already doing in all our mosques, we will try to create monthly education where we invite specialists or professionals who understand the condition very well to give us talk so that everybody within the community and the Muslim society will have adequate education and knowledge concerning this condition. And secondly, we can also hold a quarterly district education and programs as well, which are already in existence, and we'll try to strengthen this as well. We'll also carry to print educational materials in English and in all our local dialects and distribute them within our community into all our schools, our universities, our makaranta, and everywhere within our communities to help with the education, understanding of this condition so that we do not take it lightly like we used to in the past. And then within 1 year, we also hope to achieve that our imams, our religious leaders, in collaboration with the health services, our hospital within the community, whereby our imam and traditional leaders will also receive training adequately so that during the counseling process, like during premarital counseling, adolescent counseling, they will have the knowledge to incorporate all this education in order that will take the advantage of this education and knowledge to improve our health-seeking behavior, timely referral, and also prevent and pick this condition early so that they can be screened. And then we hope that in 1 year's time, while strengthening these already existing platforms that we have within the Muslim communities, we will be able to achieve better outreach and reaching out to more people who do not have knowledge on this condition, and also will have lesser cases coming with crisis. And then we also have people who have knowledge and are able to make informed decisions so that we have lesser cases of the sickle cell. And even if those that are already in the system should be able to have easy access to early screening.
Working hard to train our members. Last year, October, we had a program in collaboration with UHAS. So UHAS is the University of Hull. They have a herbal department. So we actually registered our members. So far, we have about 500 members. So we actually did a training for them, just for them to know some of the basic conditions. So we presented sickle cell cases to them. Anytime somebody come with a clinical manifestation of a sickle cell patient, so that they should be able to know. WHO made us understand that about 70% of the world population rely on herbal medicine. And here in Ghana, everybody, your first point of medicine is herbal. So, yes. So if you happen to be in a center of a traditional healers clinic, the person must be well informed. And Dr. Anson will agree with me that in medical training, all what we do, it's by history taking. I mean, take your history very well. You should be able to diagnose your condition. If you don't have the requisite laboratory center, there's something we call differentials, and that's a differential diagnosis. So the patient comes, you should be able to know, okay, this could be a malaria, this could be a typhoid, this is probably a sickle cell. So last year, October, we did it with the UHAS, and this year, just last month, we did another collaboration with Tech. That's the KNUST, also to train our members so that they will be well informed and then well capable of knowing the condition, at least some of the basic clinical manifestations, so that they should be able to diagnose. And then if they are not in a capability of resolving the problem, they should be able to refer and give immediate care to those who need care, especially the sickle cell patient. So we've really doing very well on that aspect. Thank you.
So thank you very much. Those were insightful submissions and contributions, and you have clearly stated how your institutions are going to strategize to support the sickle cell patients. Thank you very much. Let's give them another round of applause. So we'll take a photo and we'll move to the next item.
Right. 18,000 children are born every year in Ghana with sickle cell disease.
At least 1 out of every 50 newborns in Ghana is affected by sickle cell disease.
Alarmingly, 9 out of 10 newborns in Ghana are not screened for their sickle cell status.
This issue extends beyond Ghana to all of Africa, where millions of babies go unscreened each year. Many are only diagnosed with sickle cell disease after severe pain crisis, leading to needless suffering and loss of life.
Some families experience financial hardship due to high medical bills, forcing them to take loans or seek early discharge from hospitals.
Low awareness and lack of knowledge can result in severe complications, societal stigmatization, and fear.
However, it is important to know that sickle cell disease, while challenging, can be managed effectively with early diagnosis.
Just 2 minutes, please pardon us. And this will be followed by Mrs. Clementia L.W. Hamza from DCL Laboratory Products Limited. So,
with early diagnosis and interventions, many complications can be prevented.
Newborn screening, comprehensive health care, and parental education can enable up to 95 out of every 100 children.
Ladies and gentlemen, and then the organizers, ISCC. Thank you for inviting Kin Health Systems and our international partner, Orasure Technologies, to give us the opportunity to speak on the importance of point-of-care devices within the screening, case, and case management continuum for sickle cell disease. At Orasure and Kin Health Systems, we recognize that in the coming years, June 19, as National Sickle Cell Screening Day, a day dedicated for data collection and strategic action aimed at improving screening coverage, early diagnosis, and patients' outcome. A day to give an account of the past 366 days of what we have accomplished, not only in terms of speeches, but facts and figures. Today, I would like to highlight a versatile point-of-care testing device whose reliability and population screening and diagnosis has been well established. This device does not require a laboratory setting or an external power source to function. All that is needed is a small blood sample, basic operator training, and a flat surface to facilitate the capillary movement of buffered blood. Using blood obtained through the heel prick of the newborn or the finger prick in infants and adults, the test can determine an individual's hemoglobin profile within 5 minutes. It can identify normal hemoglobin, sickle cell trait, and sickle cell disease. Since an individual's hemoglobin status remains constant throughout their life, a single test result provides a lifelong information. The device can also analyze eluted dry blood samples collected from filter paper. This lateral flow point of care has been available for more than a decade and is increasingly becoming the cornerstone of sickle cell screening and diagnosis in clinics and hospitals across the country. In some cases, it helps clarify ambiguous results generated by other testing methods, including conventional hemoglobin electrophoresis. Point-of-care testing is transforming the future of sickle cell screening and diagnosis It enables large-scale population screening by allowing communities to organize screening campaigns in which large numbers of people can be tested and receive their results on the same day. The process also encourages patient participation and helps build confidence in the results. The availability of this technology significantly improved access in screening services in underserved and hard-to-reach communities, particularly in low-resource settings. It has also addressed many of the logistical barriers traditional associated with sickle cell screening and diagnosis. Furthermore, concerns regarding the availability of highly specialized personnel are being reduced through the use of this friendly lateral flow point-of-care device, which require only basic training to operate effectively. As we consider the goal of universal newborn screening for sickle cell disease, this technology offers a practical and scalable solution. It simplifies neonatal and infant screening and supports the efficient collection of population-level data for informed decision-making and improved healthcare planning. Together, we can leverage point-of-care testing to strengthen early detection, improve case management, and ensure that no child is left undiagnosed. It is our goal that every child by the age of 10 should be able to confidently inform any healthcare professional of their sickle cell status whenever they visit any health facility. Before I conclude, let me read an excerpt from the lyrics. There's a place in our hearts by the legendary Michael Jackson, and it says, "Heal the world, make it a better place for you and for me and the entire human race. There are people dying. If you care enough for the living, make a better place for you and for me." Inspired by this message, we are reminded that improving access to the sickle cell screening and care is a shared responsibility that can help create healthcare future for all of us. By expanding access to point-of-care screening, you can help build a future where every child knows his or her sickle cell status and receive timely care and intervention. Thank you, audience, for your attention. And to respond to the Saboba case, King Health Systems has a package for you. We have a small package of screening devices, phlebotomy supplies, and then some cassettes for the actual results taken. And we'll do that after this. Thank you very much.
Thank you, King Health.
Yes, indeed. I'm interested in an aspect that I didn't quite hear, probably because I was concerned, because it is after you speak that I pick the message. So I wanted to find out, I haven't heard your tool in terms of reliability and validity, because in all the tools that we are using, what stands out is how reliable it is and to what percentage, and also the validity. Because without these two things, there's no way that you can make comparison between what you have and what is existing in the system to make a choice. I'm taking the opportunity of being the chair. I know you opened this, but because I'll be doing closing remarks, I can't be asking questions at that time. So I want clarity on some of these things so that I know how to deal with them. Thank you.
10 seconds, please.
Yeah, this device has been around, as I said, for the past 10 years. It's all the time undergoing FDA registration. It has a high level of specificity and sensitivity, about 98%. Yes. And it looks like the Zambian algorithm with sickle cell, for sickle cell, a sickle scan. That's the brand that we have here. It's a very powerful tool, and as I said, sometimes it comes in handy when there are ambiguous results from some of our electrophoresis machines, and it tells the story and it closes the story. Yeah. Thank you.
Thank you Thank you once again, King's Health Systems, for your generous donation. We'll now invite Mrs. Clemencia from DCL to give a very, very short statement. I trust you. I know you do justice to it. Thank you.
Good afternoon, everyone. My name is Clementia Hamza. I'm the country sales manager for DCL Laboratory Products here in Ghana. So before Dr. Ansong chases me off, I just briefly want to talk about Hemex Gazelle HB variant point of care testing solution. So this is a point of care testing solution. It doesn't require connection to electricity. It's less than 3 kilograms in weight, and so it can be used even in the most remote areas or rural areas. It's ideal for decentralized settings. It has 100% sensitivity and 98% specificity. Before that question comes up. It works with the same principle as the electrophoresis in the laboratory. However, this is automated because it is not subjective, it's objective. So you're dealing with an automated system in the laboratory. It's also battery operated, and so you can actually put it to charge, have it charged, and then send it into the communities for your testing. As we said, the main or the primary focus for sickle cell disease is seeing what you're testing. And the Gazelle stands at the point in between the gold standard of the HPLC and the rapid test kits. And so what you get from Gazelle is you get a point of care testing device. You get a device that gives you both qualitative and quantitative information. And so you're able to not just tell the different genotypes, but you're able to tell the distribution of it for the purpose of monitoring. So it's also ideal for hydroxyurea monitoring. I'll just wrap it up here. Any more questions, you can reach out to me so that I save some more time. And then to also support with the challenges that Saboba is currently facing, we are providing one Gazelle device for Saboba, and then we are providing cartridges of 100 pieces for Saboba as well. So this is done in collaboration with the manufacturer of Gazelle, that's Hemex, in the US, and DCL here on ground. Thank you very much.
Thank you so much for the donation. Stephen, are you around? Can you please come up really quickly? We have to go to the Q&A. We are very much aware of that, and we are also very much aware of how far time has been spent. So, Stephen, can you kindly receive this on behalf of Saboba? While Stephen does that, I need to also acknowledge Zutron Pharmaceuticals. So Zutron Pharmaceuticals are the sole distributors of the Hemotype SC, and for ISCC, Hemotype SC has been the test kit that we've used from the very day one. It was being managed by Sysmex, and they gave it to us for free. The biggest donation was 10,000 test kits for 10,000 people, and we're able to screen more than 6,000 people. So Zutron has taken over, and they are also supporting a rural community. So it's not just a rural facility, it's not just Saboba that has received the donation from Gazelle, that's DCL, and King's Health, that's Sickle Scan, but then Hemotype SC is also supporting the Guaso Municipal Hospital with 100 pieces of their Hemotype SC, and we believe that someone will be saved because of that. So thank you to our partners for this wonderful support. So, okay.
I thought, Stephen, you have to receive and express your gratitude. You taking it away like that doesn't include me. So, by the powers conferred on me as chair, I command you to give them time. Now, having said that, also receiving it doesn't mean that that's all. I wanted to find out from this. There are two things. The fact that you've told us what the tools are capable of doing doesn't mean that automatically giving it to them, they will be able to operate it. When are you training them to use it, the use of it, not just the use of it, and how to maintain. And whether if there's any replacement required, we can get it immediately for replacement before they use it for 2 weeks. The third week, oh, this thing is not there. This consumable, we can't get it. This will not make us have a sustainable use of it. This is what I want to hear from the donors whilst you are receiving your thanks.
Honorable Chair, I'm very glad this afternoon, so much glad that I can express myself. Little did I know that my coming here will yield such positive results. If I had considered the distance, if I had considered the sleepless night I would have to spend coming here about 16 hours and mistakenly didn't come, this thing would have gone to another facility somewhere. So I'm very glad this afternoon. Thank you, Dr. Mary Ansong and your team. Thank you, donors. And I'm here with a lab technician. We are two here. And we'll be taking through the training. I mean, how the thing is used. We have no problem staying even 2 days. We have no problem. So thank you so much.
Okay, so just to complement what he said, yes, we were informed that he was going to be coming here, so we did request that he comes with his colleagues so that we can have the training. And also for the purpose of decentralization of this device, it is very easy to use and can be brought down even trained to nurses who move out into rural areas. This is not our first adventure, if I should say. Sister Dinah is here. We actually partnered with Chai recently and provided these devices and cartridges. And so DCL has been in the market in terms of supplying medical equipment and other products. And we're in for the long haul.
Thank you. Thank you so much. We are grateful. Now, the next donation, should I say, is to the Ghana Institute of Clinical Genetics, and it's being done by a sickle cell warrior and a Reverend Emmanuel King Foley, head pastor of Royal House Chapel International. Can you please come up, and representatives of GICG who will be taking the donation to support the clinic, please come up. Can we put it up on screen, their presentation, pictures of what they are going to donate to the institute? Thank you so much, Rev.
Thank you very much, Madam Moderator, for having me. I would like to say a big thank you to the organizers of the program. This is the very first I happen to be participating in. International Sickle Cell Center and all the ministries based in heaven. It also gives you healing, which I took, and ever since I can say without mincing words that I have been cured of sickle cell condition fully, 100%. How do I know? I got to know because since then, crisis that used to set in every now and then became a thing of the past. And when it was time for me to go get married, genotype tests had to be conducted. And strangely, I had a rare type of the SC genotype, which crisis can trigger even when the sun is blazing. And I was shocked to discover that my genotype had changed from SC to AC. Where the S went after today is a mystery. So I spent a couple of months in wintry conditions in the Western metropolis doing the work of God, and I never had a single crisis. And it tells you that doctors can do their bit, but healing comes from the Lord. And I'm so grateful to what God can do. So I'll keep praying that the good Lord who heals will give our doctors and our health practitioners the wisdom, the know-how, and whatever it takes to discover a permanent cure for this debilitating sickness. But until that is done, I want to lend my voice to the pleas and the sentiments that have been shared here today, that the authorities who are responsible will do the needful, and then also to encourage all of us who are here in our numbers, let's rise up and be care advocates. I mean, advocates of all the good things that we need to do to ensure that they need the usual palliatives, the folic acid, the BCO, and the multivitamins that I used to be on those days, including the painkillers, and of course, they need some air conditioners. So I've provided all these things that I'll be presenting. Because of space, I cannot bring them here. So just to let you know that we have been kept alive so that we can be a channel of blessing to institutions like Ghana Institute of Clinical Genetics, Kolebu Sickle Cell. So on behalf of myself and my wife, we seated out there, and the Royal House Chapel family, which is headed by the one Apostle General Sam Kranchiankra, we are here to say thank you to you and also to do our little presentation to Kolebu. God bless you. We are eternally grateful.
God bless you, Rev. We'll take a quick picture with GICG. Okay, next on the list is SGIF, but I need to say this because there's an advocacy platform. There are people, I'm a Christian and I believe in miracles, okay? But then we also need to know that if your genotype, you believe that your genotype has changed, you must go to a couple of reliable facilities and get tested using different techniques to confirm that your genotype has truly changed. And until your genotype has truly changed, don't stop taking your medications and don't stop doing what you're supposed to do to stay healthy, because it can come with serious consequences. And like I said, it's an advocacy platform, so we need to put this across. Miracles do happen, but be 100% certain that there's a real miracle. Thank you very much. So we'll now have SGIF to donate to some selected sickle cell nonprofits. We are really behind time, so I plead with everyone who is called to come up on stage to make it extremely concise, because we've not gotten to the crux of today's meeting, which is the people who are going to cause the real change. Ministry of Health, Ghana Health Service, NHIA. So let's please make our submissions really concise. Can I trust you?
No. You know, I come all the way from New York only to be told you have 1 second. Okay, without paying my airfare. So I'll be right here. So, Mr. Chairman, good to see you again. Ladies and gentlemen, all protocols observed. You know, the spirit of Dr. Kwaku Ohene-Frimpong, whom somebody mentioned, is very excited today. Why? Because in 1993, he was the first to conduct a feasibility study in Ghana on newborn screening. In fact, it was the very first in the whole of Africa. And he continued on to 2022, when you talk about advocacy, when he advocated with the Ghana government to put hydroxyurea in the National Health Insurance System. So well done. And today he will be extra happy that the work that he started here alone as a pioneer has continued. And you look at this room, and well done, Mary and Martha. I wanted to cut that part out, but I still kept it in just for you, for this wonderful conference. Okay, so it continues to Dr. Ohene-Frimpong. Just the year that he died, he founded another organization in Philadelphia. And this organization, Sickle Gene International Foundation, is supposed to raise funds to assist the work of sickle cell disease care and everything else that goes with it in Ghana and Sub-Saharan Africa for that matter. So on that note, some of you remember me, Dr. Hafiz, of course, from November 2025, when we held a conference here at Turmeric. And in that conference, we did say that we would give out some mini grants. as a start, just to test the waters and see how things go. And today I am happy to be here to announce that we do have 4 awardees of these mini grants, and Sickle Gene International Foundation, of which I'm the executive director, and Dr. Jacqueline Owusu Mackenzie is the chair. We are just excited that we have this opportunity here to be involved, because as they say, every beautiful thing starts with money. And to solve every problem, you need some money. And we say here in Ghana that he who would share his little with you is the same who will share his big with you. So on that note, I'm delighted when you hear your name of your organization, if there's any representative here, please come forward. We had 12 applications. We definitely wish and extremely wish we could stretch our hands to all, but this is just the beginning. We hope and will work to have more that will go on. As I'm listening to everybody's presentation today, I see that we also have a lot of work to do on the other side of the Atlantic to bring the resources here to do the work. So Sickle Life Mentorship Project. Now, each of these organizations will get a letter, an official letter from us. Anybody from Sickle Life Mentorship Project, please just come forward for a picture up. No? Nobody's standing for them? Anybody? Yeah, I thought so. Okay. And then the Lord's Blessing Foundation. Lord's Blessing. You're going to be blessed today, so come on down to be blessed. The Lord's Blessing. Okay. You standing for the Lord's Blessing. And Faith, Hope, and Love Group Africa. Faith, Hope, and Love Group Africa. Anybody? Okay. Martha, come and stand in for Faith, Hope, and Love. So you can tell them. And Greater Accra Regional Hospital, anybody here from RAGE can please come on up. Here's Prof. All right. So you can go back and do your job. Prof, come on down. Okay. All right. So here they are, and you will hear from us more formally. And congratulations. I did it, right?
Somehow he tried, because he can really talk. So thank you so much, Dr. Boateng, for the support to these organizations. We are truly grateful. Now, we've been sitting for a while. We need an icebreaker, so we'd like to call Pon Jasper and his sister to come and give us a very short performance. Let's give them a round of applause. Let's clap until they get here. They are young children. No. Let's clap for them. Let's give it up to them.
Sometimes I'm happy, sometimes I'm sad. I don't know what's over me. Sometimes I'm good, sometimes I'm good, sometimes I'm wise, sometimes I'm wise. I don't know what's over me. what's over me. I'm overthinking everything. At times it feels like nobody can understand the way I feel. Cause I am fucked up totally.
I don't know how to keep company, so I've been drinking cognac. I've been drinking.
Drink too many shots of cognac. One for the belly, another for the broken heart. 3 for addiction, 4 so I don't go back.
Looking for somebody with me, watch my shoulders, so I can never be sober.
I am not a stranger to the dark. Hide away, they say, cause we don't want your broken parts. I learned to be ashamed of all my scars. Run away, they say, no one will love you as you are. But I won't let them break me down to dust. I know that there's a place for us, for we are glorious. When the sharpest words wanna cut me down, I'm gonna send the blood, gonna drown them out. I am brave, I am bruised, I am who I'm meant to be. This is me. Look out, cause here I come. And I'm marching on to the beat I drum. I'm not scared to be seen. I make no apologies. This is me. This is me. Oh yeah. Oh yeah. Oh. Yeah. Sometimes I'm happy. Sometimes I'm sad. I don't know what's over me. Sometimes I'm good.
Sometimes I'm good.
Sometimes I'm wise.
Sometimes I'm wild.
I don't know what's over me. I don't know what's over me. I'm overthinking everything. At times it feels like nobody can understand the way I feel. Cause I am fucked up totally.
I don't know how to keep company, so I've been drinking cognac. I've been drinking.
Drink too many shots of cognac. 1 for the belly, another for the broken heart. 3 for addiction, 4 so I don't go back.
Looking for somebody with me, watch my shoulders, so I can never be sober.
I am not a stranger to the dark. Hide away, they say, cause you do me like this is me.
So I think we are having some technical difficulties. Oh, okay.
Do me like do me like Shadie, boom, yentem, boom. You go do
do them like juju. Kakalika, kalika, kakalika, kalika, kakalika, kalika, kakalika, kakalika, kalika, kakalika, kalika, kakalika, kalika, kakalika. Kaba, hey kaba, see them around, no hide for the tight, gonna, we know the shake mana, wanna, we know the fear, wanna, they know the easy, we know be in for that, wanna, them all are informants, them all are informants. Kalika, if I dance and they just manika, no we be caterpillar, you go see one day we go 10 to killer. Kalika, if I dance and they just manika, no key we be caterpillar, you go see one day we go 10 to killer. Shaggy, boom, yentem, boom, they do me like boom.
Let's give it up to them. Okay, so thank you so much for the wonderful performance. Sorry for the technical hitches, but this is Jasper and his sister from DWP Academy. If you want them to perform at your events, please get in touch with them. They are doing this voluntarily, free of charge for us. So that's their dad as well. So let's acknowledge their support. They are coming all the way from the eastern region of Ghana. Yes. We were supposed to get up and dance a bit, but because of time, we are going to move on to the next item on the agenda. Can you please put up the country experience from Uganda Ministry of Health by Dr. Miriam Ajambo, because we are moving to the crux of why we are here, from policy to action. So would like you to put up her video so that we listen to her presentation. Then we move to panel 2. Panel 3, yes. Media, please help us. As we wait for media, let's have the speakers on panel 3, Dr. Ernest Esiedu, the head medical and dental unit, Ministry of Health, join us on stage. Let's please give him a round of applause as he does. Then Mr. Isaac Obintando, who is a field epidemiologist from the Ghana Health Service NCD Control Program. Let's give him a round of applause as he comes on stage. Let's also receive Pelumi Okuyemi, an associate at Clinton Health Access Initiative, CHAI. Let's please welcome her with a round of applause. We'll also have Dr. Salamatu Atta Nantogma, who is the Deputy Director, PPME, Ghana Health Service. Let's receive her with a round of applause. It's like our applause is hungry. We are hungry, eh? Sorry. There is lunch for all of us. Yes. Then we'll also receive a representative, someone standing in for Dr. Ruby Eileen Mensah. Sorry, I missed your name. My apologies. She's a Deputy Director, actually, for the Strategic Health Purchase in National Health Insurance Authority. My apologies. Yes. Let's also welcome Teresa Opon-Mensah, Director and National Coordinator, SHEP Ghana Education Service. Let's give a round of applause. Media, please, is our video ready? Or do we move on? Is it ready?
Greetings from the Ministry of Health of Uganda, and thank you for Greetings from the Ministry of Health of Uganda, and thank you for inviting me to share insights into how Uganda has been able to advance the fight against sickle cell disease. My name is Dr. Miriam Ajambo. I am a pediatrician by training and the National Coordinator for Sickle Cell Disease in Uganda. I just want to briefly share some milestones that we have registered as a country over time. The fight against sickle cell disease started way back in 1968, at our national referral, Mulago Hospital, when a clinic was opened to take care of patients who had sickle cell disease. We had a very committed professor, may his soul rest in eternal peace, who dedicated himself to enrolling patients in care and giving what was available then to improve their quality of life. And then over time, we had comprehensive care come in, where a number of medicines would be prescribed, and including IV fluids, to be able to, some medicines to prevent infections, and then, the blood transfusion came on board, and the fluid management to be able to manage the crisis. So over time, in 2010, is when we see sickle cell appearing in our policy document on non-communicable diseases. And that was a great milestone, because a few years later, in 2015, we see a prevalence study that was then done to determine the burden of the disease in our country. And that is the data that we rely on. We are at 13 to 15% of our population carrying the trait of sickle cell disease. And in some districts, the prevalence goes. Establishment of 10 centers of excellence to do comprehensive care and treatment for sickle cell disease. These include our regional referral hospitals that are now able to enroll children, mostly children, in care and be able to give the comprehensive care and management, including hydroxyurea, which came on board, which was actually incorporated in our essential medicines list in 2016. And we are also proud that the government has availed some funds to be able to procure hydroxyurea, and we distribute to our facilities free of charge. It's not yet good enough, but it's about $27,000, which is actually very, very, helpful. We run out of stock from time to time, but this has been very helpful. And over time, we've seen partners come on board. Like in 2024, one of our partners came on board and is supporting 2 of our regional referrals to have buffer stocks for hydroxyurea, but leveraging the stocks that come from government so that they just, supplement. We also have had newborn screening being scaled up to more facilities, and to this year in February, we launched nationwide newborn screening. We are not yet there. It's still taking shape. But with the launch of the locally manufactured test kits for sickle cell disease, we are seeing many more facilities able to screen newborns and on site. Unlike previously when we relied on centralized testing, our central public health laboratories do a lot, and we do not want to continue to overwhelm them with all the samples that come from around the country for newborn screening. So we have embarked on on-site newborn screening, and we also have point of care machines that do HB electrophoresis. So all our regional referrals actually have HB electrophoresis point of care machines that are able to, do quality assurance after the qualitative test, the rapid diagnostic test. We also registered a milestone this year when we had the launch of locally manufactured hydroxyurea. We've been relying on imported hydroxyurea, but starting this year, we believe that we will have more hydroxyurea readily available and at a lower price for government to procure for more patients to be cared for. So with support from our civil society organizations, we continue to have advocacy, and government has continued to own up this fight. And now we see that it's completely embedded in our systems at Ministry of Health and at our facility level. So we will continue to, ensure that all patients that are diagnosed are in comprehensive care and get the comprehensive care and treatment. And then we are continuing to have more awareness creation. Actually, we still have a big gap in awareness creation and prevention of the disease. And we are hoping that there will be more resource allocation towards this so that communities embrace premarital testing and ultimate prevention of this disease. We also are hoping that our data capture can improve so that we continue to inform resource allocation and planning at national level. But for sure, we have registered great milestones when it comes to testing and treatment and linkage to care. Then also, follow up of our patients who are already in care. So what do I share with Ghana today? That government ownership is very crucial. The Ministry of Health the Ministry of Health of Uganda has owned up this fight. And that's why you see that I am a national coordinator working in one of the departments at the Ministry of Health. So government ownership is very crucial, and dedication of resources for this fight, because there are many arms to the fight. There is awareness creation and prevention, there is early testing and linkage to care, there is comprehensive care and treatment and follow-up of these patients. But also there is the M&E component, the data capture and reporting. So we need resources dedicated to this in Ghana for us to be able to fight very well. And then to ensure that this service actually goes up to our primary health care facilities. We have already started on this one in Uganda, and we are progressing very well. And we hope that all our primary health care facilities can actually support with early diagnosis and care of these patients, even as they work with the community to create awareness. And value your partners. Partners are very crucial. They have been able to support us a lot and bridge the gaps that government, cannot yet fill up at the moment.
Thank you so much, Dr. Miriam from the Ministry of Health, Uganda. We now move to the second part of today's discussion. Sorry. Yes. Let's share. So, like I was saying, we'll move to the second part of today's meeting. This session brings together leaders across policy, implementation, planning, financing, and partner support. Our focus is on practical actions, institutional commitments, and the reforms that are needed to make quality sickle cell care accessible and sustainable across Ghana. So, because of time, we would like to immediately begin with the Ministry of Health. I'm very happy to see all of you here, and we are honored that you made the time to stay and be on this panel. So, Dr. Isiedu, Ghana has developed policies and guidelines for sickle cell disease screening, diagnosis, and management. From the ministry's perspective, what progress has been made in translating these policies into action, and what role should government's leadership play in driving a stronger national response? Thank you.
Thank you very much, and good afternoon to everybody here. And all protocols observed. My chairman is here, and the chairman is also the coordinating director in the same directorate where I'm working. So I will leave some of them so that he can say. Yeah, so generally, as you rightly mentioned, we first had to identify the priority diseases within the non-communicable disease space. So in 2022, yes, we were able to launch the non-communicable disease policy and strategy, and teasing out from there the priority diseases. Sickle cell is one of the major non-communicable diseases that Ghana has prioritized. And then we were able to launch our strategy in 2024. And then from there, we've been able to launch the case management and also screening guidelines in 2025. And now we are in 2026, it's implementation. One thing that I would like us to recognize is that the health sector in Ghana is very pluralistic. So currently we have about 20, almost 30 agencies, and then also by association that we work with. One of them is what we have just, a couple of them are what we have just observed here in terms of the donation. Government or the Ministry of Health cannot do it all. And that is the reason why we work closely with partners. And partners have come to make donations here. And these donations, I would say that are very important for it to be captured within the Ministry of Health scheme, because we do admit that we will not be able to do it all. And that is why we work closely with partners. In fact, today should have been a day where the alliance is set up, we'll have maybe one lunch in the ministry, and ultimately various partners would be able to continue the work. And again, I must say that this is just a day that we are celebrating in terms of the discussion, but then the fallout of what is happening here day by day until next year is what is critical. So we've been able to do these documents and we've been able to launch them. The rest is actually its implementation. And it's quite exciting for me to see that the implementation is part of what we are observing here. And we need to recognize that whatever any partner comes on board to do, please also let the ministry be aware. Currently, we're doing a lot of work with Chai. Chai supported us in developing these documents. And part of the work that we recognize is what Chai has done. Again, I think Madam Hamza also talked about the support that they also provide in terms of the equipment, the point of care testing equipment. You would recall that not long ago, the free primary healthcare policy has been launched, and we are working on it in phases. The first one includes the awareness creation, where community health nurses are going to be educated or are being educated to be able to provide the same information in terms of awareness for the public to know. And I think that the previous panel have also talked about awareness creation, especially Madam who sat here and told her story. The other thing is also related to the prevention, which my colleague from the genetic counselor has also talked about, because sickle cell disease is something that can readily be prevented. Of course, I've had a lot of conversation with Mary around what we need to do, but nobody is going to ban it. I've been telling her that if I have the opportunity, I will ban these couples, because that informed decision that we talk about, if it was only going to affect me, would have been okay for me to make that informed decision. But the unfortunate incident is that the impact is on other people we are bringing. And my own classmate, who is already a doctor working at 37, for those who go to 37 military hospital, they were twins. One was an engineer, the other one was a doctor. And almost alternately, this one, goes into crisis, the other one goes. So virtually, they were almost always in a hospital. Thank God we finished school, and then the brother, unfortunately, passed on a few years later, the engineer. And then the one at 37 always entertained fear that they were identical twins, they were also going to die. And unfortunately, he also passed on. At a point in time when I think Enam was telling her story, she said that even to pick a vehicle, you are very, very disadvantaged because you can't pick trotro. It means that you need a lot of money to either take an Uber or have a driver to take you around. And you and I know that the economic situation is not like that. He had to be put in a car, brought to the hospital, run a clinic, see patients, and then had to be put in a car to drive back. So the Ministry of Health is fully aware of the challenges that we are all seeing as far as this is concerned, and we are partnering with all our agencies to ensure. Colleagues are here to talk a little bit more about how these are translating into real action. So I'm not going to delve too much into it because my colleagues are here. Otherwise, I'm going to say everything. They won't get anything to say. But we are at the policy level. What is important, just like the lady from Uganda talked about, Ghana is also adopting the same way of the point of care testing. I would say that a number of institutions supported by CHAI has started. Other institutions, other partners are also supporting other regions and other areas. And I think CHAI is doing 4 regions at the moment. We do have other partners also supporting other regions. And ultimately, in the phase 2 of the free primary healthcare, this is one of the things that is going to be moved as nationwide newborn screening for the country. So I won't talk too much so that I can allow my colleagues to also speak. Thank you very much.
Thank you so much, Dr. Siedu. So you handed the baton over to Ghana Health Service, the implementers. So, but the thing is, we want to move from policy to action. And since Ghana Health Service is under your jurisdiction, we have to make sure that the Ministry of Health is enforcing the implementation, and not just enforcing, also giving GHS the capacity to do what GHS has to do. So there's still work on the side of Ministry of Health. Yes, a lot of work. So we'd like to now hear from you, Isaac. From the Ghana Health Service perspective, what progress has been made in sickle cell screening, diagnosis, linkage to care and case management? And where do the biggest service delivery gaps still exist for patients and families? Thank you.
Thank you, Mary, and good afternoon to you all. Yes, for what my mother ministry has said, yeah, it actually sits within that. So basically, the ministry lays the foundation for every service delivery. And I must say that the ministry has been instrumental to lay all the structures for the service to deliver. However, challenges still exist. With respect to screening, there is still a major gap. Not every newborn is screened because there are logistics not available, or there are human resources not available to conduct this screening. So with respect to screening, I must say we are doing well, but not to the whole, 16 regions. There are over 11,000 facilities, over 8,000 children's compounds. It is expected that these services are provided in any day a child is born. But that is not what we see now. To some extent, we are making some progress. But I will only also touch on how the service is looking at decentralizing a comprehensive sickle cell intervention. And we are not doing this alone. The ministry has given the direction and the guidelines. Partners are on board to actually support us, scale this up. And that includes ISCC when they will join in future to provide some of this support. And we encourage you all here. Hill, let me use this opportunity to let Hill know that at the NCD control program, we have the SCD focal desk where we coordinate every SCD activities. So if you have any programs that you want to implement at any region, please, our doors are open. We at the program is open to all partners. We've even mapped out all partners within the NCD space where we join, we coordinate activities and even encourage networking among ourselves so that we don't implement activities in silos. So please come to the office. We are there to ensure that our activities are well coordinated. Coming back to linkages and treatment to care, because of trying to break the access barrier, we are to zone the country so that at least some comprehensive care for sickle cell can be done at every region. So right now we have started, Chai has supported with some facilities giving a comprehensive care for sickle cell disease. Some district hospitals are also yet to receive some of this. With time, we will get there, but for now, it's still a challenge. We encourage partners to join, and then we are happy to have some partners already contributing to it. Thank you, and over.
Thank you, Isaac. I have a follow-up question. What is the gap? What's the main challenge on the ground that is not giving Ghana Health Service the needed muscles and capacity to solve the sickle cell challenge the way it would have loved to?
Yeah, so I would refer you to the health system building blocks. It's mostly commodities and health system financing. We have human resource in all our facilities. We have human resource who are skilled to provide sickle cell services, but they don't have the commodities, and then they don't have the resources to replenish these kits and medications that are needed throughout the year. So for us as a service, it's more of commodities. I admit that health insurance provides some sort of financing when it comes to medication, but it is not the entire continuum of sickle cell care. And then patients get to the facility, there are financial constraints, either facility is also not able to provide the requisite services. So for us, the governance, leadership, everything is 100% for now, but health financing and commodities is what is lacking. And once these are not available, of course, the end user, who is a sickle cell patient or sickle cell warrior, will suffer. So for us, that is the major gap. And we have a CHIPS compound in every electoral area. So if every electoral area is able to screen, of course, we address the access issues for our caregivers, patients. Thank you.
Thank you so much. Thank you so much, Ghana Health Service. I'm talking about health finance, and I think it's just right to move to National Health Insurance Authority. And we would like to know from NHI's perspective, what progress has been made in supporting access to sickle cell disease care, and what financing strategy is needed to make essential medicines, diagnosis, and routine care more affordable and sustainable for families? Thank you.
Okay, thank you very much. Good afternoon, Dr. Sedu. Riding on all existing protocols, I would take off from where Dr. Sedu and my colleague from the Ghana Health Service started or ended. So for NHIA, we recognize the financial burden that sickle cell places on families, especially individuals who are affected. I remember very well from secondary school, I had colleagues who were, in serious or difficult crisis that parents had to come in and take them home. And so working at NHI and seeing the benefits package and all that we have in there, I feel that is a matter of sensitization here, because we cover a lot. We cover from medications to treatment to diagnosis to even flare-ups or disease management. And so in order not to miss words, for some of the medications that we cover hydroxyurea, folic acid, morphine, paracetamol, brufen, diclo, codeine, and for diagnosis, HB electrophoresis, full blood count, GCSPD, among others. There are a lot on our benefits package that we cover. But I think also it boils down to our tariffs. All the time they go to the hospitals and they say that we don't cover, mainly because our tariffs are low. And so the National Health Insurance has taken steps to review our tariffs. So very soon it would come out, or it will be rolled out very soon, and we would know a lot that the package has in stock. And for the financial bit of it, National Health Insurance doesn't directly purchase from pharmaceutical companies and among others. So what we do is we take opportunity of the market access programs to negotiate for price rebates. For hydroxyurea, for instance, we had to negotiate with Novartis on how we are able to absorb for our clients. And so we take opportunity, or we take opportunities from these market access programs to be able to negotiate prices, but we don't buy directly from the market. So this is one of the strategies. And also for the free primary health care that will be rolled out very soon, there's also the opportunity for newborn babies. Yes, please, it's been launched, sorry. Yes. So for the launch of the free primary health care, there's an opportunity for newborn babies with mothers who are positive to be screened from the onset. So this gives us also the opportunities for us to pick them up early and continue the care and the management. Thank you.
Thank you very much. Thank you very much. So that is what there is with National Health Insurance. Let's move to Miss Okuyemi from Shy. Chai. Okay. We want to know what support has your facility provided so far, the impact the support has achieved, and also the lessons that have emerged about sustaining and scaling these gains through government systems.
Thank you very much. So just for the benefit of those of us who might not know what CHAI is actually called the Clinton Health Access Initiative. So the acronym is CHAI, so you hear that a lot. But just to say that we have sort of just situated ourselves as a trusted partner for the government, working in close collaboration with the Ministry of Health, the Ghana Health Service, all the important parastatals that we need to work with, the NHI, just to make sure that we're pushing and supporting the agenda as is stated in the National Strategy for Sickle Cell, to ensure that we are helping the government to roll these activities out. Our support really is mainly across 4 interconnected areas, starting with diagnostics expansion, capacity strengthening, health system integration, policy, and market access. Just like our name access, we do a lot of market shaping across, globally, just to ensure that we are bringing low and middle income friendly pricing for diagnostics, commodities, treatment commodities, essential for the treatment of everyone. In particular for sickle cell, we, together with the Ghana Health Service, conducted a facility assessment just to understand the gaps, to be well informed on our implementation for sickle cell. From that point, we were able to look at the gaps in screening, treatment, and monitoring. And that led us to procure 116,000 point of care LFA tests for SCD. And that has been distributed across 25 health facilities in 3 regions in Ghana. We also procured Gazelle device has been presented today by HIMEX. More importantly, to bridge the gap that we have seen in terms of fetal hemoglobin monitoring for HU initiation for children, especially in the health facility. And that has also gone through 16 health facilities across 11 regions in Ghana. Just to note that some of these facilities are also district level facilities, and that is really pushing the agenda of decentralizing care within the health facility so that there can be more people that would access this care and don't have to travel all the way to like urban centers to get the care. More so, we have negotiated prices, global access prices for these commodities, the hemotype SC, the Gazelle, and even HU, bringing it down so that more governments, even beyond Ghana, can actually procure these commodities and make it available within their country for the respected persons. On health system integration, we, continue to work with the government and ensure that there's a co-creation, co-designing for sustainability measures in the country beyond our support. And this has also led us to work with the Ghana Health Service to co-design a sickle cell e-tracker that's embedded within the DIMS, and also taking cue from the PEM Plus register to ensure that all the indicators for sickle cell is being imputed into this. And this over time is meant to sort of replace a fragmented paper-based system that we have in the health system to ensure that governments have more informed surveillance for sickle cell so that we can really talk about what our prevalence is, our burdens are, and then governments can actually make an informed decision on that. In terms of policy, and just like, Ministry of Health has talked about, we did support the case management guideline development and its launch. And moving into creating commodity access, we are currently supporting the Ministry of Health and the health technology assessment, and trying to ensure that
what is dictated in the national strategy for newborn screening and catch-up is actually implemented, creating access to routine newborn screening for sickle cell. And also looking at how we can put HU on the framework contracts to widen that gap, just as NHI has mentioned. We government needs to get into a place where we're negotiating with vendors within the country to make the access for HU wider than what it is right now. And as NHI is also looking at increasing or adjusting their tariffs, it's also able to cover the available HU we have in market so that there's more access for that. And all of this is really just pushing to ensure that we're supporting the government's response to sickle cell. In terms of our lessons, I think the first thing that we have learned really is that co-designing with the government is not optional. It's actually the mechanism that actually drives sustainability. And so we're making sure that everything we're doing sits within the coffers of the government so that they can take that on beyond our support. And whatever we can do to also support the implementation of that, all the strategies, all the case management guidelines, all the guidelines, we're able to do that. Second of all, looking at procurement. Procurement without designing procurement needs to be done in a way where we're pulling in government investment and not necessarily replacing it. So we've talked about procurement of 116,000 commodities, 16 gazelles here and there, but it's not meant to replace what we have in country. It's meant to just pull in the investment of government. And by doing so, all the commodities that we have procured are intentionally framed to be a bridge to demonstrate demand, to establish the supply chain system that will also make government think about creating an investment for certain disease areas, for SCD in particular, and inform them on, commodity procurements in the future. Thank you.
Wonderful work that you are doing to support the governments of Ghana and even other governments. And I think for me, a personal concern is how do we move from donor-led initiatives in Ghana when it comes to sickle cell disease to government-led initiatives that other agencies, donor agencies can support, nonprofit organizations can support. And it sounds like even beyond ministry agencies to do their work efficiently, because all of you on this panel, everyone has a good will and heart for sickle cell disease, but unfortunately sometimes you are attacked, especially NHIA, and it's not your fault. You are well-meaning Ghanaians. So how do we move from policy to action, Dr. Asiedu?
Thank you very much. So I think I had mentioned it, but I may have to reiterate the point. So I will not say that this is donor-led. If you recall, I talked about the fact that we tease this out of first there's a national health policy, and then the non-communicable disease policy and strategy, and then the sickle cell. I think that we just have to avert our minds that I have mentioned that government cannot do it all. And that is why we've extended a hand. For example, the number of Ministry of Health staff who are at this program tells you that we are supporting our partners to be able to achieve what we intend to do. So the document is developed, and then in it, you would always see there's something we call implementation arrangement. What government must do, what the private sector, what civil society, and we are all working together to make it happen. Chai has given, or I had already mentioned that there are parts that Chai has taken up. It is government-led, and then partners are supporting that particular direction. I think one of the things that we must also remember that NHI is taking care of about 95% of all known conditions in Ghana, and they fund it. And she mentioned that tariffs have become a little bit of a problem. That is the reason why sometimes the facilities, instead of providing the service on the National Health Insurance, they try to decline. And if you recall, the minister has not been very happy about this, even though the tariffs may seem to be small or may seem to be not as optimum as it's supposed to be. It is not all conditions that so if you run an entire system, you may benefit some from one place, you may not get so much from the other place. But again, she has also mentioned that the tariffs have been revised. And if you heard from maybe the CEO or the deputy CEO, has been revised as high as up to 120%. And sooner than later, when it starts operations, the minister has mentioned that co-payment and also taking top-ups and things, those words are not going to be accepted in its implementation. So this is not just for sickle cell disease, but it's also going to take that opportunity. And again, I mentioned that with the rollout of the free primary healthcare, that focuses on promoting health in terms of awareness creation and disease prevention. The point of care testing will be rolled out for the newborn screening in the phase 2. Currently, we are going to do more advocacy around the awareness creation, and I'm happy that SHEP coordinator is here. And I don't want to delve too much into it, but I think what I keep saying is that yes, we want to do the newborn screening, but there are so many opportunities where somebody would definitely have to know their status. Again, one, for example, at newborn. Secondly, we start the child welfare clinic at 6 weeks. At any point in time you come in contact with the health system, this is going to be an opportunity to do this. When you are going to school at the kindergarten, now the public sector starts school at kindergarten. So when you're going to kindergarten, there will be a requirement for, let's say, what you have in your road to health chart, which now currently is the combined one. There's also an opportunity for the testing. Now, when you are getting to when you finish JHS 3 and you are going to SHS, that is also another opportunity where you know. And then when you are going to the university. So as we discussed, when you get to the point of making your mind that you want to marry, that is when the love will turn your head around and you will not be able to think well. And that is the most dangerous part, where the outcomes might not be good. And of course, nobody is blocking anybody, but these are opportunities. Secondly, if you look at what the Reverend also talked about, there are opportunities that now churches have adopted. There are various youth groups, and from time to every year, almost every church that I know has a health week, at least in the year. So these are all opportunities where a lot of the health promotion related issues are going to take place, and screening and blood donation and other things are going to come up. So I would say that there are a lot of low hanging fruits. There are a number of organizations where typically I call natural places of gathering, where there are good opportunities we can tap into. So all these things have been captured in terms of the implementation. And recall that everything we do in the health sector is also holistic, and we don't want to take just one part and run it, leaving the others. We do not want to leave anyone. So if you take the universal health coverage roadmap that Ghana developed, so there's health promotion, there's also disease prevention, then there is curative care. So that part is what NHI has covered very, very well in the past. And then now the introduction of the free primary healthcare, taking care of the promotion and the disease prevention component. Then there's also rehabilitation. We've talked about people go to the hospital for, I think the madam was talking about 10 months on admission. So schools, you're going to lose out and all. So people have to be rehabilitated and reintegrated into the system so that they can become productive. Recall that sickle cell tries to put you at a certain disadvantage, because if you are in crisis and you are not going to school, there's a high probability that you might not be able to become very productive in society. So all these are opportunities where we are looking at, and ultimately palliative care, which is not end of life. Right from the time that you are diagnosed for sickle cell, then you immediately know that certain things in terms of your lifestyle and all these things are very important, how you go about it. And that's why palliative care. But during these periods, there's also an opportunity for mental health support, both for the person who has the disease and then also for family that are supporting. I recall that my colleague, for example, in terms of relationships and things like that, because of peer-prism and these things, I mean, he never went into any kind of nuptial relationship and things like, because he was almost always anticipating that he's likely to die and that didn't want to bother anybody. And then the other bit is also emergencies that may arise out of you being diagnosed sickle cell. So just like anybody may run into any kind of emergency, whether it's medical or surgical emergencies, they are also prone to the same thing, apart from the fact that they are at risk of some of these things. So like you rightly said, we are very, very averse to, we know for sure that these are things that we really need to work on. And the ministry is taking steps to make sure that these things do happen. And again, I'll say that we will not be able to do it alone, and we need to work closely with partners. Partners would take the policies. I know that a lot of the things we do now, partners would come and say that we've seen the document, and these are the areas that we want to show interest in and want to support. So we want to continue to encourage. But the last bit is that as we collaborate and we partner, we want to set a system where if any partner wants to do anything for any part of our system, it has to be brought to the attention of the entire health structure, right from the community level up to the national, within the service delivery, as well as the Ministry of Health. So these donations that have been done are, I think, very good, but has to be known to the ministry and maybe even the Ghana Health Service headquarters, because Aboba is a facility within a certain region, within a certain district, and has to be captured so that when partners come, we do know that we can even direct them appropriately to where they need to go. And I just want to use this as an advocacy platform that if there's any partner that is doing anything in a particular district or in a certain region, please ensure that you are working with the district health directorate, the region, and also make the ministry become aware so that we can guide the process appropriately and to ensure that we can sustain what we are doing. Thank you very much.
Thank you very much, Dr. Asiedu. Dr. Natoma. So as Ghana rolls out the primary healthcare bill, we want to know, could you help us, the audience, understand what the bill covers and how sickle cell disease is reflected within that scope? We'd also want to know how SCD data is integrated when it comes to national planning, budgeting, monitoring, and accountability systems.
Okay, thank you very much, and good afternoon to everyone. And I'm thinking that after Dr. Siedu has spoken a lot about free primary healthcare, I seem not to have too much to say. But I think that I just want to say that the primary healthcare bill is the legal backing for the free primary healthcare. So it gives us an opportunity to be able to implement free primary healthcare as a right to every Ghanaian. It also defines the scope of the services that is supposed to be provided under the free primary healthcare. And as has been mentioned, the free primary healthcare is very heavy on preventive and promotive care services, where we have the genotype screening and also newborn screening as a critical aspect of it. NHI has mentioned that as part of the free primary healthcare, there is the screening for babies born to mothers who are sickling positive. And this is because to a large extent, we don't find our men anyway. So we will use the women as a proxy to be able to reach out to know which children to screen and not to screen. And I must say that the free primary healthcare, we've all spoken about financing, gives a very good opportunity for sustainable financing. And that is what the bill is allowing us to be able to do, that the government is making a firm decision to say that free primary healthcare will be funded by the NHI. And so we know that for all the preventive and promotive care services, we are able to fund it through the implementation of the free primary healthcare. I think what I want to mention is the fact that listening to the Uganda experience, one of the things that was most critical was the fact that they took leverage of other programs or other initiatives that were ongoing. And with the implementation of free primary healthcare, we are integrating everything into the health systems. So as part of the free primary healthcare, we also have outreaches, we have home visits, and this gives an opportunity for the community health officers to have direct contact even with the communities, and we'll be able to reach out to people living in the communities with sickle cell. So this helps, it's more like a very intimate kind of relationship with the community, so that you pick up some of the things we have spoken about today. You have early signs of someone who probably has not been screened before. The community health officer's capacity will be built to be able to ensure that they pick up those cases as well in the community. Everybody in the populace has the opportunity of being screened at least once a year. And I think that will open up a lot of the issues about preventive and promotive when it comes to sickle cell disease as well. What free primary health care or the bill allows us to do as well is to be able to integrate a lot of telemedicine and tele-support to our lower levels. So today we heard from Sabuba. I admire the work that he's doing in Sabuba, and I'm thinking about the fact that what about the other areas that do not have someone who has the passion or the drive to be able to do that? We need support to a large extent to be able to manage cases, and that's what the telemedicine aspects allows us to do. And thankfully, NHIA as well, this time is also going to be paying for telemedicine services as well. So that allows for remote support of rural areas when they have to manage sickle cell crisis and all that, and they need support at the lower levels as well. In terms of data, I think this morning or the whole of today, what we have said is sickle cell is a real issue. Why are we not taking the critical decisions? And I think that the only way we can tell the story is by having good data. And most importantly, I believe that we have to disaggregate the data. When we have sickle cell data, it is embedded into all the non-communicable diseases, especially when I look at the data that we collect. So you may probably have morbidity data that will say sickle cell, or maybe mention the diagnosis the person may have come in with. But to a large extent, when we have the aggregate data, what does it translate to? Does it take out sickle cell as something that we should pay attention to? When people living with sickle cell develop end organ issues, whether renal issues, whether they have strokes, how do we see it in the database? We see it as stroke. We probably may not see it as stroke secondary to sickle cell something, or we may not see it as renal failure secondary to this. And I think that is what we have to look at, building the capacity of healthcare providers to be able to put in the right diagnosing coding that gives us what we have to take decisions on. I can just imagine that to a large extent, when you look at the data, a lot of the acute chest syndromes will end up as pneumonia in the database. So I see pneumonia, I see it as generic pneumonia. I don't see it related to a particular group of people. So I think that it's really critical for us to disaggregate the data so that we can tell the story that is specific to sickle cell. And based on that, it can be costed. Because if we don't have the data that disaggregates it, we are not able to specifically cost or put it into budgeting and be able to say that this allocation goes specifically to sickle cell. It may all be embedded in just one lump and all that. And Shai has mentioned that we've had some support from them as well to deploy eTracker. So eTracker is transactional data collection tool that is linked to the DIMS2 that allows us to take data at the community level. And those are some of the tools we are looking at to be able to ensure that we improve digitalization at the lower levels as well, remove all the paper-based data entry, removes errors as much as possible. And also there's also the deployment of the GIMS, which is also at the health center and the district hospital level. The Ministry of Health is also working on the health information exchange that allows all these systems to be able to speak to each other. And if they speak to each other, we know that we don't have data that we are losing alongside because you are moving from one place to the other. There is data scattered along the line. And of course, continuity of care, this integration allows for continuity of care. So whether my community health officers took my data in the community during screening, or I went to the health center for care after that, or I was referred to the district hospital because I had a crisis situation, we should be able to get a data flow that flows across every digital tool that you use, which is speaking to each other. And that gives an opportunity for a life course data for people living with sickle cell. Thank you.
Thank you so much. From what we've heard so far, it's telling us that at least the future, there is hope. in the coming months, and we are in hope. According to Dr. Siedu, we are in hope. So very soon we are going to have the mobile van that our chairman mentioned. NHI has reviewed the tariffs and everything, and we have the free primary healthcare bill that's focusing on sickle cell screening in the communities, and also access to essential medicines. And yeah, so we are very excited about our current, no, I would say, Dr. Sedu says we are in hope. We are excited about the, we are in hope. Okay, we're excited that we are in hope. So because of time, we'll move to the ministry, no, the Ghana Education Service, and would like to ask that from the service perspective, what role can the education sector play from kindergarten through tertiary education? I think Dr. Sedu touched a bit on it, in strengthening sickle cell education, screening, awareness, and support for students living with sickle cell disease. And what policy or institutional actions should be prioritized moving forward? Thank you.
Right. You mentioned that you want us to move beyond policy to see what is happening. And from KG is age 4, KG1 is age 4. The moment you enter KG1, one of the documents we request for is your weighing card. And we pick some information from there. Aside picking that information, there is screening, also health screening from the lower level up to class 3. That is one key area. Then from class 3, another point where we screen again is class 6. And then that carries you throughout to JHS. And then from JHS to SHS, there's also compulsory screening for all our students. We have screening protocols, 17 of them. And one thing that we also need to do in this screening protocol is the genotype screening. We need to integrate the genotype screening into the screening protocols. Another document that we also look at when we want to know the health status of the students is the admission form at SHS. And then also at JHS, when we are seeking admission, we are supposed to declare the health status of our children. Not because we want to stigmatize, but in order for us to support that child. And this is where a lot of parents are failing. They don't disclose. And that is a big challenge to us. So in most cases, we say, oh, the child's condition is serious. But we didn't have any information on that child. And so the teacher or the house mistress didn't know what to do at the time that the child was in crisis. Then aside that, in the cumulative record book, we are also supposed to indicate the health status of that child. And again, this information is not provided by the parents, so we hardly get to know the health status of that child. So for all parents who are here, these 3 key records are very important to us, and we need to. I have also nursed a sickle cell child before. And I don't want to talk about it. It's a bit emotional. I don't want to talk about it. He's no more anyway. And when I declared the status of my boy when he entered SHS, the housemaster asked me to share the same information with the housemaster closer to his house, so that when he is not there and the boy needs help, the other housemaster will come in. And I did that to the head of department as well, plus another teacher. So I never had any challenge when he was in secondary school. All the time there were people there to support. When you take these records aside, in our curriculum and then in our health education interventions, we do provide education on disease conditions for the students as well. And Ghana Health Service has been so helpful. The recent one we are doing is with together with Ghana Health Service and CHAI on type 1 diabetes. And it is not just sensitization for the children, because when you enter the school, there's a triangular kind of intervention where you need to touch the child, the teacher, and then the school community, especially the parents. So with CHAI, one of the trainings we did for teachers, there was a particular teacher who wept throughout the training because he was now learning about the condition. He didn't know. So he recollected that there were some particular students he could have helped, but he couldn't because he didn't understand their situation. In the earlier presentations, we heard this, where teachers do not have enough knowledge on the conditions, and so they think that supporting the child, or the child is just trying to present something in order to dodge some assignments or some work that they have to do in the house. I remember one doctor who said he was in the school and the teacher said, "Now, we'll say your answer so away so news." Yes, because that person has not experienced it before and the person doesn't understand what the child was going through. So he was refusing to grant exeat to that child. So for our teachers to understand some of these conditions, we need to build their capacity. We have mapped all our schools to health facilities and it's working perfectly for us. But in the house where your ward is, there is a teacher, and that teacher is acting as a local parentis for that child. So that house mistress need to understand the condition. And so we need to build the capacity of all teachers, be it at the KG, primary school, or SHS, for them to also understand the situation and provide a conducive environment for the child. There's something that I've been trying to do and I'm not getting support. Guidelines for supporting learners with chronic health conditions, and sickle cell is one of them. We have guidelines for school health services, but the teachers in the school, the children in the school, what kind of support can we give these children who have this chronic disease? I had a call last year when we were doing admissions for first years, and the head was Madam Enti. She said, "Madam Enti, yebe." Then I said, "Admit her." "Madam, Monsieur, are you?" Monsieur, "Admit her." "Madam, Mamina disclose the health status, but the child herself says she is this patient." Then I said, "Yes, admit the person. Pick the contact of the mother for me. We will talk behind the scene." And I said, "Madam, me and you are the only people who are aware of this child's condition. We need to protect this child from stigma. And so I will come to your school together with another person from the health sector, and we will come and give you education on how to handle this child." So if all our teachers will be given enough education on the condition, then I think they will be able to provide the necessary support. Not only the teachers. I'm saying this because in the secondary schools, we have non-teaching staff as well. My daughter doesn't eat from the dining hall. She eats in the matron's office, and she eats a special diet. So those kitchen staff, the matrons in the schools, and then the nurses we have put in the school clinic also need to have some information in order to provide the support for the child and also make the school conducive place for the child to continue with the education. We want to see every child attending and benefiting from education fully and not being separated or staying away from school because of some health condition. And so that brings me to the point of revisiting the hospital schools. It seems we have few in the country, but we need it because I visited Kolebu, and a boy who was in KG was on admission because of cancer for almost 2 years. So that's almost 2 years Lessons were ongoing in the classrooms, and this boy missed. Because he has missed, are you telling the boy to go back to KG1 where he was before he started, before he went on admission? The same thing is happening to those living with a sickle cell. So if we can strengthen the hospital schools, they will also benefit fully as their other counterparts are also benefiting. Thank you.
Thank you so much.
Thank you very much, Mrs. Mensah. So far a lot has been said, but as we come to a close, we want each rep to give us one concrete action that your institution can support within the next 12 months that can support sickle cell disease in Ghana when it comes to policy to sustainable actions. Each.
30 seconds.
So within this 12 months that we are talking about, we are currently doing screening in some of the districts within some regions, and the tool we are using has given us a feedback that we need to review the screening protocols. So we will take advantage of that and then integrate the genotype screening into it. And also, if we can get some materials, education, because we handle age different groups, we need age appropriate materials to be able to do education for our students as well as the school community. And so if you will give us those materials, we can easily do this education for our children, our teachers, and then the parents as well. Thank you.
Thank you.
Thank you very much. I think from our side, in terms of some decisions are supposed to be policy led. So looking at the situation and the conversations that we've had, I would propose, my director is here, that maybe in the second phase of the free primary healthcare, sickle cell newborn screening is included. So that is what we will push to make sure that it happens. And of course, National Health Insurance Revision would be able to take care and fund that. Thank you.
All right, thank you very much. So once my boss pushes for the newborn screening, of course, Ghana Health Service will implement that. Yes, but for the low-hanging fruits, I believe we've touched on awareness. And like I mentioned, we are in all electoral areas. So we would, for the next 12 months, we will intensify awareness on sickle cell diseases. And then hopefully, we are also hoping to decentralize sickle cell interventions at least for the district hospitals. They should be able to do that. So the document is under development. We're hoping that in the next 12 months, it is being launched and then implemented. Thank you.
All right. So for us, really, it's just to continue to work with the government and make sure that all the work is something we can continue to piggyback on. Earlier this year, we trained 369 healthcare workers across, 11 regions, and we can't do it alone. So one thing that will be a priority for us is to work with as many partners as possible to continue to support the government, within the Ministry of Health, the Ghana Health Service, to continue to institute comprehensive care for sickle cell. More importantly, standardize the national protocols for sickle cell care and management. It's something that we have seen that is very important. When you go to these different facilities, they all have their different protocols, but thankfully with the case management guideline, there's a protocol for treatment and screening, but we really want to work with the government to standardize that protocol across all the regions, across all the health facilities, to continue to bring the work to light. Thank you.
So thank you very much. So I think that from where I sit, I will go with this aggregation of the data. And I must say that we are available. We are looking forward to be able to support this aggregation of data. One thing I want to say is that disaggregating the data is very easy. getting the right data in is the one that is most critical. So again, jumping on what Dr. Asiedu said, it is very difficult to do it alone. We will need a lot of support from partners to be able to ensure that those collecting the data at the service delivery point are collecting the right data and filling it at the right time. So that's what we'll work towards.
Thank you very much. So for NHI, a collaborative effort with the Ministry and Ghana Health Service on the free primary health care that seeks to screen newborn babies with mothers with positive sickling babies, and also the rollout of the pending tariffs. Once they are out and the figures, just as my brother said, is over 120% increment. And so if it comes out and the figures are very good, then out of pocket payments and all that will be eradicated, hopefully. Thank you.
Encouraging. We are actually in hope, like Dr. Siedu said. So we'll give the opportunity to our audience, both online and in person, to ask questions to our panelists. So if the ushers can help us pass the microphones around. Okay, can we see by hands those who have questions? Well, that's a lot. So 1, 2, 3, 4, 5. Great. We'll take 5 questions, and that's it because of time.
Okay, thank you very much. My name is Padmo Osei. I'm a master's student, genetic counseling. So I've actually learned a lot over here, but then my question has to do with the policymakers. So as genetic counseling students, sometimes the challenge is that even though we are saying that we need a lot of education, sometimes you go to the hospitals, you even try to volunteer, and then you send your letters, nobody even calls you for just normal volunteerism where you would want to just speak to the patients. So I want to ask, are there any plans as policymakers where they would want to integrate genetic counseling services in the primary health care and in maternal health programs? Thank you.
So we would like to take the next question. We'll put all the questions together, then we answer them.
Hello, please. My name is Michael Adade Anan. I'm a pharmacy student at Entrance University. I'm also the SRC president. My question is in 2 parts. The first part is we focus more on patient counseling and also counseling before marriage, that we want to prevent people who are carriers from getting married. But I look at the data of students or for young children, teenagers, and we have about 100,000 births by teenagers every year. I'm not sure these counseling policies aim at these young people. So do we have specific policies tailored towards these young people? And then the second question is, as a pharmacy student, I've been in the pharmacy and I've had patients come in that we have crisis, but we don't have any medicine or hydroxyurea. Since the pharmacy is the first point of care that most people run to, do we have any policies to subsidize the price for community pharmacies? And also, some patients come in and they say, I want meperidine or I want petidine because it is the drug of choice. And I know sickle cell is driving people to become addicted to these strong medications. So what policies are there in place for such people? Thank you.
Thank you, Michael. The next question, please. Okay.
Hello, everyone. My name is Golda Jenny Mbwati. I'm a student at the University of Ghana. I have sickle cell disease myself, and I founded this global network called the Resilient Red Network. It's a student-led initiative on campus to create awareness in tertiary universities, tertiary institutions, and then also mainly to support people psychologically, because SCD can pose a lot of mental issues on caregivers and warriors as well. Well, my question is about health workers' sensitization on SCD. I've had a very bad experience with one health worker where I needed to get morphine very quick, and then I couldn't get that because right now we are under scrutiny and judgment. Aside having painful crisis, people, as Michael said, are scrutinizing us because they think we are addicts and then we are seeking drugs. We are drug seekers. It's very painful because we have we don't have policies like this or support groups that can help us to navigate problems like this. So the health givers need to have empathy on us too, because it's not our fault that we have sickle cell disease. And so what are some of the initiatives or policies that you have in place to sensitize these health givers to have empathy on us and help support our care? Thank you.
Thank you.
Question.
Thank you very much. I have a question and a very quick comment. My name is Dr. Yao Ansong. I'm a physician scientist. I'm a brother to Dr. Mary Ansong. I was very... Oh, God. And Martha. I was very excited when everyone was talking about the newborn screening. And I know that a lot of the companies were also trying to sell their products. My concern is that globally, the standard for newborn screening, typically, they don't focus on just one disease. And I know it's sickle cell there, but we are at risk of neglecting some other diseases. I'm curious to know if the planned program plans to incorporate other diseases. And then my quick comment also with the empathizing with the pain, there are objective tools and microfluidic tools now that can be used in disease assessment. And I've been involved in some of that work, and I'm willing to provide some support if anyone is interested here. Thanks.
Thank you very much.
Yes, so we'll pass the microphone round for answers to the questions.
Okay, thank you very much. I will attempt to answer some, and then my colleagues will also add on to it. I think before a program is introduced in this country, GTEC will have to accredit the program. But if it's a program that requires that ultimately its recruitment or the employment of the product would have to fit into the health sector, then a certain regulator is responsible towards that. So if we are already providing genetic counseling, or we have a program for genetic counseling, I can assure you that it's a priority for Ghana. That is the reason why the program is running. And then they are supposed to be incorporated or recruited within the system, within the Allied Health Professions Council. So I was on the board for, and I know that there was a presentation that was brought to us for us to look at where these professionals will fit. And we have already agreed that it would fit into the Allied Health Professions Council. And at the time, we're also discussing with the Psychology Council which of the two would be able to, but it's more clinical than just psychotherapy. But again, it's also psychotherapy. So I want to assure you that the ministry has prioritized, because it's very important. You look at the areas where you put interventions for prevention, and it will save you a lot of money for curative care. So the one who was asking about it, I must say that it's a priority for the ministry. That is why the program is running. And products from there will be recruited to provide the needed support. The part that you said, but again, I think it goes back to education and awareness creation, that maybe somebody might not necessarily understand the reason why a student of the particular program wants to come and offer voluntary service. So it's difficult to say that at the level of policy, we have not agreed to it, but maybe at the operational level, that is where some of these challenges are. So once you have brought it to our attention, what the ministry can do is to write to the various institutions that we should open up and then allow students or residents of certain courses to be able to provide some service or to come and learn on the job what is going on. So that is what I will note. Maybe my director would also... Exactly. So the institution can write to the ministry. My director is reminding us that it has to be formal. So once we know that this is a gap, this is how we can write to the various institutions where you can provide them. Again, even in the schools, I'm sure Madam may talk about it, but if you write to the Director General or the Ministry of Education that these are things that we intend to do, they would also write to the schools to open up their doors for that.
So if you want to do the counseling in the schools or even to offer sensitization in the schools, you need to write to GES and we will grant you permission to go. Thank you.
Thank you very much. The other one is also related to prescription-only drugs. It will touch on yours and then also the pharmacy. Yeah. So these are prescription-only. We are also learning because, again, I think this morning we heard that someone said, I'm following the WHO ladder. So we do know that patients with not just sickle cell disease, but other conditions, including cancers, require a special kind of pain management because pain itself can also kill you. So there are different capacities that people have. Sometimes we have also made it it looks a little bit strange who can prescribe and who cannot prescribe. So again, in terms of capacity building, we have that responsibility to ensure that people are also made aware. And then as part of scaling up or spreading the knowledge about how we manage pain or various kinds of crises in different conditions, including sickle cell. That is so. I'm happy that you brought this up. We've taken notice of that. It means that there's a gap, and that is why a patient should not even demand or ask for us to also provide us to think that the person likes drugs and wants to be on drugs. But you cannot walk into a pharmacy and say that I want to purchase. These are prescription-only medications. So we need to play our role well so that our patients, we will not miss that part of it where they need to go and do that. Again, I don't know whether you've shown the video because I stepped out a few times, but if the video was shown, we do know that we're not about people marrying, because we know that not everybody marries before they have a child. So you showed the video, right? So it focused on before you become sexually active. And I'm happy that Madam has already told us the various opportunities where we can have access to testing, for which reason we should make that informed decision. And again, it's incorporation into the curriculum at the basic, the secondary and tertiary level, something minimum so that everybody who has contact with the school or any other place would at least know that it's important that we know the genotypes, or some awareness is created at any point in time when you touch base with the system. Then the aspect of, I think the health worker sensitization is also very important, because I cannot give what I don't have. So it's important that we do know and be able to empathize with our patients, because even though somebody is a health worker, might not necessarily have come in contact with a sickle cell patient who is in crisis. So it's all imagination and things like that. And we have not also felt the pain before. So sometimes, but the awareness creation for health workers is also important. Recently, during the Health Summit, one part of work that we also have alluded that healthcare providers also have challenges, and we also need help. So in terms of mental health support, if I'm not very sound, when I see you, I would also bring my problems on you. Not that I'm a doctor, so I'm very sound. We do have our own problems in terms of the stress and everything that goes on. So we have identified that and looking at the mental health support for health workers and fitness to practice. And this across all healthcare professionals. We are working on that one. And finally, I would also talk about the panel of screening. So again, we've been having conversations. And if you heard me, I was talking about the fact that sometimes sickle cell advocates are pushing for sickle cell, hypertension, cancers, and so we look at it holistically at the health sector. We have had some proposals around newborn screening, not only for sickle cell, but a number of other conditions. So for example, the pediatricians and the neonatologists have told us that commonly hypothyroidism, some other conditions are a bit more prevalent. But because we have not also tested, we have no idea whether these conditions exist in the country. But we have some proposals looking at these things. But it's the funding that is always the challenge. So who is going to fund a constellation of all these things? And I think that these are conversations that we can have, to move this forward. Thank you very much.
Thank you so much. I think. Okay, just to add on to some of the questions, I think the issue of the counseling for the teenagers, the Ghana Health Service has the adolescent program and they have adolescent corners in their hospitals. Yes, I agree with the fact that they need to be strengthened. They have their own issues of stigma that people don't want to be seen going to the adolescent clinics because they have been tagged with uh, girls who have bad intentions of having contraception and all that. But that is what the adolescent program is meant for, to be able to support adolescents to be able to take decisions during that time, and also have counseling for sickle cell and all that. To add to the subsidy issues when it comes to the pharmacies and medications for sickle cell. So when free primary healthcare is fully implemented, community pharmacies are also parts of free primary healthcare, and they are supposed to provide services, and they'll also be reimbursed, from the NHI. So that's, to a large extent, is also covered, including actually school infirmaries, marketplace clinics and all that. So they are all parts of it as well. And we are looking at the fact that by the time free primary healthcare is fully implemented, it will be a per capita payment. So all the health service provision points will have to work as networks. And that is where the is actually coming as well in that aspect. I think that for the rest of them, and also just to clarify the issue of implementation level when it comes to having attachments in facilities. So there are processes, like everybody has said, there should be a formal request. And let's remember that now there are a lot of schools and there are a lot of people that come into the facility. So sometimes the facilities are overburdened with people coming on attachment. You can have a ward of probably 20 patients and the students there are 60. So it's a challenge, and the facilities have to manage it. So your schools have to be able to send in the request early enough. There has to be an agreement to be able to say how many students can come at a time, so that the facilities and all that can plan as well. Thank you.
Okay, sorry. Please, I wanted to chip in something. So for guidelines for hydroxyurea, it's only at the tertiary level. So you can only access at the tertiary level. But for the other medications like the morphine, the paracetamol, and the others, folic acid and others, are at all levels, right from the CHIPS health centers going up. Thank you.
Are you looking at integrating and taking it to like the district facilities, and even can it get to the CHIPS center? What's the plan like? What's the reality on the ground?
It's a level of prescription, yeah. So it can't go, yeah. We have levels of prescriptions for all the medications that are put on our benefits, yes. Yeah.
But we've just revised because of the primary healthcare delivery. We have just revised the prescription level of some of the various facilities. And so if it is to be brought to lower level, it means that it has to go through, a committee that would look at it and say, yes, we can bring it down to one level as we are looking at the capacity of those who will be prescribing. So we need to do assessment before that can be done. Thank you.
Thank you so much for making the time to help us understand the current state of sickle cell disease in Ghana, progress, challenges, and the way forward. As Dr. Siedu said, we are in hope, and we are looking forward to seeing tangible results on ground next year when we gather to still look at the same theme. Thank you once again. We are very grateful. We'd like to give them a round of applause and take a photo.
Let's give them another round of applause. Because of time, we have to take some things off the agenda. We are going to receive a presentation by Fam Mathariafi, my co-founder, who is going to talk about the situation on ground when it comes to access to essential medications. I'm sure there'll be other opportunities to do that. And then my siblings, I had to sacrifice them. My brother, Dr. Yao Ofoswanso, was also going to talk about gene therapy for sickle cell disease and finding a cure for Africa, because that's his specialty, from UC Berkeley. There'll be Zoom seminars, yes, to deliberate on these. Is Irekwa from Reha Pharmaceuticals with us? There is something special that they've brought on the market, which we've been really looking forward to for a very long time. It's caused a lot of challenges for families, people traveling from different parts of the country, coming all the way to Accra to access it. So we want to give her like 2 minutes, something really short, to tell us about what they have and what they are bringing to the Ghanaian market. And then we plead with you to stay, do not leave, because we are almost through with today's conference. But thank you so much for making the time and staying through up until now. ISCC has been doing this work of impact for 5 years, and we would like to cut a cake with all of you and share it with you, just to commemorate our 5th year anniversary. Erekwa, please, the stage is yours. Let's give a round of applause as she comes.
Good afternoon, everybody. Thank you for your patience. So, as we all know, hydroxyurea has been established as the gold standard for therapy for sickle cell disease. But for pediatric care, there are still some barriers to their treatment, some of which is with the formulation, the reconstitution of the capsules. Sorry. The reconstitution of the capsules into the suspension has a short shelf life, about 30 days, which means that most of their patients and their caregivers need to travel from wherever they are to the manufacturing units to have their capsules, their suspension made for them. Also, the suspension that we make it's not stable at room temperatures, meaning it requires cold storage. So for people in the deprived communities, rural areas who don't have access to refrigeration or electricity, the suspension we make does not last long. Then we have the problem of yes, thank you very much for that. To reconstitute the suspension, you need to manually open the capsules. Hydroxyurea is cytotoxic in nature, so the healthcare professionals themselves are at risk. Plus, it's also time consuming because it's not as simple as maybe crushing paracetamol or anything. Hydroxyurea is very delicate, so it needs proper procedures to ensure that the product you made is safe and effective for the children. So looking at these challenges that we've observed over the years, we have pharmaceuticals. The company I work for has partnered with Akum's Drugs and Pharmaceuticals and Pure and Cure Health in India to come up with a drug, to come up with a new formulation, the same hydroxyurea, but has been stabilized in a suspension form, already liquid to use. It's ready to use in the liquid form, which is accessible for all children. It cuts the cost of having to travel from wherever you are in Ghana. Yes, thank you for that. This is the product. It saves time and energy. You don't need to travel from wherever you are in Ghana to, say, Kolebu manufacturing unit just to have your suspension made for you. It's also already in the liquid form, so there's no need to disperse or to crush or to shake or whatever. You just need to draw your suspension and then give it to the child. Because we know hydroxyurea is administered based on the weight. We have made syringes specifically for the kids, and the strength is 100 milligram in 1 ml. So there's accuracy and flexibility in the dosing. You don't need to be too rigid with say, the capsules come in like 500 milligram, but this one has been made in per mil. So it's easy for you to just draw out the dose you need and give it easily to your patient. So Rehab Pharmaceuticals has collaborated with about 9 hospitals in Greater Accra since receiving our FDA approval, and we are ready to work with other hospitals to ensure that the children who need access to we want to make the children's lives easier for them. So we are ready to collaborate with all stakeholders, Ministry of Health, Ghana Health Service, NHIS, to ensure that our children receive the care they need. Thank you very much.
Thank you very much. Please, can we get a table here to set up for the anniversary cake? So as we wait for them, let's have the saxophonist to come and entertain us. We've been sitting for a while, right?
T-boom, T-boom, boom, boom. We will get there. Heaven knows how we will get there. We know we will get there. It will be hard, we know that the road will be muddy and rough, but we will get there.
From prestigious awards to tangible impact on millions of lives, March 2021 brings back fond memories of our journey. It reminds us of when our founders, Dr. Mary Ansong and pharmacist Martha Riafe, decided to embark on a mission to dedicate their lives to the cause of sickle cell disease. This came at a very heavy price. Both founders had to resign from their professional work and commit 100% of their time to the International Sickle Cell Center, ISCC. With the support of a dedicated team that works with empathy, visionary senior consultants, and committed partners, we've made significant progress towards achieving our mission, despite countless setbacks. We have created families within our community with enduring relationships grounded in professionalism, empathy, and support. Having conducted free sickle cell screenings for over 6,000 babies, children, adolescents, and adults, we have helped many know their genotype for the first time. And yes,
since inception, Mary will not give me my peace of mind. When she picks the phone, she will speak for 30 minutes. And so I say, Mary, I was busy doing something. Can we cut it off? But I'm very happy for her. She was my former student. And the story is a long one, but she was so determined to take this on. And I'm very happy that 5 years down the line, this is where we shout, Ebenezer! How far the Lord has brought us. Shall we give a clap unto the Lord? Ebenezer, 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 Ebenezer. This is how far the Lord has brought Mary, and Martha is here, and everybody who is standing here. The support of our Ministry of Health, I salute, Director. Dr. Siedu, I salute. Everybody, I say thank you. Thank you for supporting my 2 daughters. And they have come this far. And this is the beginning of greater things to come. Say amen to that. Amen. And without much saying, we're going to cut this anniversary cake. In the name of... We are cutting this cake in the name of the Father, of the Son, and the Holy Spirit. Amen.
Thank you very much.
We have been able to donate vital medical equipment and medications to over 5,000 people in 13 regions, educated over 8 million people in and outside of Ghana, sparked hope in hearts, taken some back to school, helped a warrior get her dream job, paid medical bills, and
Thank you very much. Those who are at the far end, can you move forward? You join us. Usually, for those who know how I chair activities, particularly important ones such as this, we need the same number of hours that we spend on all discussions for me to be able to say what I want to say. The last presentation, that one, the marketing, the name was Eurakwa. The one who just marketed the product. Eurakwa, where are you? Oh, how? I wanted her to mention the name for me. Sikane Hwai. She, throughout her advert, she never mentioned the product. You are talking about the product, and you never mentioned it. No, it's okay. Don't come and spend time here. Yeah, so when we are promoting a product, it's only fair that you mention. So, ladies and gentlemen, as I said, I know we are to go for lunch, isn't it? And I know we are all tired. But I also want to hold on to the things that I think we have gone through. But looking at Prof, I think that I'll spare you on inflicting on you a 7-page notes that I've taken, including the ones that I have to take to Minister of Health to deal with. So I'll begin by saying that we had our opening remarks by Professor Gladys, who has sat throughout. Usually you don't get this type of opportunity to have an elderly prof to sit through from the morning up to now. Has she taken her lunch? Not yet, you see. So please let's give it. So she had an opening remarks and welcome address. And she started by appreciating all of us for making time to be part of this glorious contribution and efforts. And she said they are expecting contribution from all of us to enhance the efforts that have been made and also to bring the dreams of International Skill Set Center to a reality. It was followed by the introduction of Chair with an archaic biography, but never mind, I accepted it. The next thing we had was a rep of the WHO. Are you still here with us? These are some of the things. So you come and deliver your speech and you go. So if we all listen to the part that we want to listen and go, by this time there won't be anybody here. So, but he highlighted the necessity of collaboration. And that's very vital that we collaborate from all angles to be able to achieve the good things that we desire to have. And that Ghana has made progress. And whilst we have made progress, there are still gaps. And those gaps, we need to work at them. He has also highlighted the support that we've gotten from them, and that key areas they consider is a consideration of Ghana's digital, and as I said, the collaboration, the digital aspects. They contributed and they supported us, but they still need. They still say that we should go and expand it. The next speaker was the special address that we got from Dr. Christopher Mensah for Tobinco. I think that the aspect of Tobinco was very vital because they also said that it's a collective responsibility that we all need to have hands on deck and to play major roles. He highlighted the funding of ISCC, that after all the speeches, the beautiful speeches that we deliver, who then takes the responsibility of supporting them financially to be able to do these things that they are doing. Then we seem at that point to be tired. So a BB Groma interlude came in to revive our attention with a beautiful Palongo dance. But we're all expected to join them. Unfortunately, because of shyness, we couldn't join them. The next speaker was our special guest of honor, who, after speaking, sought permission from the chair. I didn't tell you, but he whispered to me that he was asking my blessing to be out of here. But he shared his personal experience for as far as the disease is concerned, and I think we all heard it. And that there's a generational bridge that we need to address between Ghana and Caribbean. Apparently, because he's a special envoy for the Caribbean, he highlighted the similarity that we have, cultural closeness, and he thinks that having 66% of the global sickle cell condition in Africa is a worry, and that we must work at it. Then the next person, we had the Ambassador Hammond, who represented the former president, President Kufuor, and he expressed the appreciation of President Kufuor for the invitation and the honor done him, and he blessed the meeting because he said the President Kufuor wishes the conference a success and hopes that the tangible outcomes will be addressed out of this. After which we had a photo session, and then comes the keynote address by Dr. Saidu Bekin, who represented the Director General, Dr. Samuel Kaba. So he indicated that the theme for this year highlights the necessity of collaboration and also the issues that border the SCD is wide in scope, and we need to have in mind when we are looking for solutions to widen the scope of the various areas and elements. And to work to improve it, we will need digital platform that will be used to track and manage the disease. He indicated that resources and collaboration with partners are essential to make sure that we address the issue of SCD. He also highlighted flagship programs such as the free primary healthcare, the GET Fund, and as well as Ghana Medical Trust Fund, popularly or otherwise known as Mahama Cares. That all these interventions are geared towards addressing, or within them, we have the element of sickle cell issue to be addressed. Then we had 20 minutes to have a coffee break. I don't know whether the coffee eventually came. Because when we went down, I was looking for the coffee. They said it wasn't ready. I said, but then if it is not ready, why are you calling us out? Then we have the premier, the firm, and the founder used the firm to tell us, that's Dr. Mary Anson. She gave us a background to the firm, and she went, that was when she narrated, she went into a relationship innocently, and things evolved and culminated into seeing what we are seeing today. And so it tells us that negative issues, when they come, you can turn them around to get positive aspects out of that. Well, and many other areas that are hard to reach and underserve. And so then we heard from their narrations the story of Zita, as Madam Emma narrated. And I could see some people were at the point of shedding tears. And yet they went through it. And these are the things that should urge us on to be able to support and make sure that the issue of SCD is addressed. Some of the key issues had to do with data. Then we also had the issue of screening. It might be widened to take care of the rural areas such as Saboba and other places. Then gaps in service delivery in terms of funds, geographical locations, and resource distribution for the management of sickle cells. There's also the unpredictability of sickle cells disease in patients. That should tell us that we have to, in our study, make sure that we look at it holistically. Then the shared experience with us. The Ghana Institute of Clinical Genetic Study also told us the need of having resources to be able to contribute their quota in terms of addressing and attending patients. The plight of underserved areas, the issue goes beyond health, as we had narrated, because yes, you may have all these things. What about the bar rules? Is it the issue of Ministry of Health? No. And so what about the cold chain issue? What about the transportation? What about the funds to even transport the person with this a sample to the next place? So these are the issues that go beyond the Ministry of Health and asking for other sectors to put their hands on deck so that we'll be able to address it. Then they also raise the issue of awareness, access to medication, resource mobilization, and also even thinking of making SCD a program. Yeah, like we have a NCD program, NTD programs. These were things that were suggested. Following that, we had our second panelist, and that was made up of a team from faith-based organizations to use our education, mount on the structures that are existing to be able to inform the public. Then the herbal medicine practitioners are also saying that you can't leave us out. We are also into the arena of delivering services. And most of you, your first point of call when it comes to addressing a condition or health condition is our product. So don't forget that we are also part of the whole thing. The next thing we had was the KHS, Kin Health, am I right, Limited. They are into the high tech, and they introduced a tool to ease in the test of sickle cells that will give us results within 20 minutes. And I think that with these tools, they will enhance our capacity in terms of diagnostics, and it has become a cornerstone, and it can test, as I said, many people and will give the results quickest. And that was when I asked about the sensitivity and the reliability of it, which he answered that it was 98%. And so at the end, a package of screening devices for Saboba was received with thanks. I think if they are here, let's acknowledge the gesture. Yes. Then we also have the homage, the Gazelle tool was also advertised, because I consider all these things, I believe they have supported in one way or the other. So we need to give them that platform, because once they are contributing, we need to know what they are doing and also be interested in the products. Then we have the Sickle Gene Foundation. They also donated a number of test kits to also Saboba. I believe that maybe by next year we are praying that to go beyond Saboba to include other areas. Then that was when I believe they saw some people a bit having their necks tilting one side from the other, and then they call in what they call the WP Academy. Those two young men who came and they did AI dance, So if you were born before the computer, you won't appreciate. Then the next thing we had was a presentation, the virtual presentation we had from Dr. Miriam from Uganda, who shared their experiences, and I think it was worthwhile. So if you look at her presentation, it was chronological. How they realized that we are having about 2%. And yes, there's a need for us to talk about, but she said that they started with 25%, huge number, about 500,000 babies with sickle cells. And so they started in 1968 when they realized that it was what was happening. They began in 2010 with a policy that translated into coming out with a study, and that study also began in 2013. And so they look at their service program was drawn, including the hydroxyurea, the use of it, screening was scaled up, and resources were provided for their 10 regional hospitals. And so they have since started giving, but they have even started the local production of the consumables, which is encouraging. Then after that, we had the panel 3 that was looking at a practical action, which has just ended. And there are a number of issues that we looked at under that. So we look at the efforts of the Ministry of Health as far as sickle cell disease is concerned, with policies backing, and they are being implemented together with the free primary health care. Then they highlighted the collaboration with partners, which are also ongoing, but we still expect that many more will join. So even though structures are in place, screening coverage is still low, which we need to work on. And the country has been zoned, as we're told. So if you think we're not doing anything, we've been told that the country has been zoned to make specialized case accessible to patients, so that we know that we don't have resources to cover all the regions. But at least if we zone north, middle, and southern, you have the opportunity at least to get your services. Then we have the NHIS. It does a lot in terms of screening and management and medication, including sensitization. They cover all this. And so if we didn't know, support from partners, example, CHAI, has really helped in the provision of resources to be able to manage the sickle cell disease thing. The e-tracker, for instance, to manage surveillance is also helping the system to strengthen the services. Then we looked at the issue of co-designing, co-creation, and co-implementation, that's the way to go, so that you don't sit for them to push what they think will work on your neck to implement. Then the data disaggregation is an issue that we have to look at. But once it's embedded into the overall data that we are analyzing, the sense of seriousness as far as sickle cell disease is concerned will not be seen. It will not be palpable. And so if we disaggregate the data, we will then appreciate the seriousness and apply same to the issue of SCD. We are also asked to establish the norm under the GES in terms of screening from KG1, or they said it exists and it is compulsory. I was happy to hear that. The only thing is that it may exist, it may be compulsory, but if it is not implemented, if it's not monitored whether it's being done or not, we'll not know. Even though it's compulsory, we still have what do you call death penalty for armed robbers, but armed robbery is still going on. Is that not the case? So we have to monitor. So then we are also asked to make sure that we encourage disclosure, particularly when we are admitting students. We need to ask the parent to be able to disclose so that we'll be able to factor how do we manage the condition of students with SCDs, and that will be helpful. Building capacity of teachers will help when it comes to the management of students with that condition, because if you are a teacher, as has been said, and you don't know how a patient with sickle cell behaves, the tendency is that you ignore, and the consequences of that will be dying. Decentralization of screening at all district facilities will be implemented in collaboration among agencies together with the Ghana Health Service and Ministry of Health is key to achieving reduction of SCD, or at least if management. After which we had, I was happy that when we got to question and answer session, it was managed well because we allowed just 5 questions, and they were expecting good answers, and eventually they got excellent answers. So major of them were centered on policy and also issues of resources. We will all know that it's a difficult terrain and we are working with everybody. And then we ended the whole session with the cutting of cake after the pediatric sickle cell product was introduced to us. So we cut the cake and we are waiting for the distribution of the cake for people to have a taste of it. On this note, ladies and gentlemen, I want to express my gratitude to you for doing me the honor as a chair and for enduring my chairmanship, even though I shared my chairmanship with the MC and the moderator. It got to a point they were not consulting me, they were just running and sitting. Anyway, that's on the lighter note. Thank you very much for your support.
Thank you so much, Dr. Hafiz. And we also appreciate you staying through up until this point. Once again, I'd like to say that we appreciate all of you for staying up until this point. We would now like to receive the vote of thanks from Miss Irene Hamba from the Ghana Health Service Health Promotion Division. Let's give her a round of applause as she comes up front to give the vote of thanks. Then this will be followed by closing prayer by David Akande, CEO of One Desire Foundation. We'll still try to do some few things that we're unable to do, which is have the musical interlude by the saxophonist, and then a video that was supposed to be played after the closing prayer will play it on screen. Thank you, Irene.
All right, thank you. Distinguished Chairman, in this course and your continued commitment in advancing sickle cell awareness, prevention, diagnosis, and comprehensive care. We also acknowledge the invaluable contributions of healthcare professionals, researchers, civil society organizations, patient advocacy groups, community leaders, traditional and faith-based leaders, media practitioners, and all participants who work continues to strengthen Ghana's response to sickle cell disease. To persons with sickle cell disease and caregivers, we express our deepest appreciation. Your courage, your resilience, and lived experiences remain at the heart of this work and remind us why our collective effort matters. As ISCC marks its 5th anniversary, we are especially grateful to all who have helped us to celebrate this milestone with meaning and joy. We sincerely acknowledge the Tang Palace Hotel, the Samuel Amotobin Foundation, Concepts GS, BC Medicals, DCL Laboratory Products Limited, King's Health Systems Limited, Zutron Pharmaceuticals, SGIF, and all individuals and organizations whose generous support has added warm beauty and celebration to this occasion. We also extend our sincere appreciation to our special guest of honor, His Excellency, former President John Agyekum Kufuor, for his support. To His Excellency Kwesi Chei Dakwa, His Excellency Dr. Winfred Neokai Hammond, and elders Dr. Samuel Amotobin and the representative Dr. Mensah for honoring this occasion with their presence and support. Our heartfelt thanks also goes to the xylophones and the keyboardists, though they are yet to do us the honor. Jasper Blue and his sister from the DWP Academy for the beautiful dance performance, Albert Cakes for the generous cake sponsorship, and Reverend Samuel King Foley for his thoughtful support. Finally, we thank the ISCC board, management, staff, volunteers, planning committee, protocol team, media team, and everyone who worked tirelessly behind the scenes to ensure the success of this conference. Ladies and gentlemen, as we conclude, let us remember that meaningful progress will not be measured only by the conversations we have had today, but by the actions we take after today. May the connections formed, the commitment made, and the ideas shared here translate into tangible improvement in the lives of people living with sickle cell disease across Ghana. For your presence, partnership, and commitment to this cause, we say thank you. Thank you, and God bless you all.
Thank you. If that clap was for you, I think you can do a better one for yourself, as you stayed with us from 9 a.m. all the way to this time. So we are about to pray and then end the event, but I would want to say some things. My name is David Akande. I am also a sickle cell disease patient, and I have an organization. And I was here today to volunteer because of the work of ISCC. They've been doing so well, so I'm just here to learn, and then I have some of my team members here. As we are all here, we are just learning so that we can also carry the conversation ahead. Yes, the conversation doesn't end here. It continues with us going home, telling people about it, sharing the story, or all the same. And also, Ghana Health Service is having like a live chat on TikTok tonight that they are encouraging everyone to join on TikTok. So you just search for Good Life on TikTok, and then you can join the conversations. I'm sure many people have questions that needed answers. If you send it over there too, you can get your answers. And June 19th is just a day to celebrate or share sickle cell disease things, but the whole of September is actually Sickle Cell Awareness Month, which we can push and do more things. We have a book from one of our board members outside called Psychology of the Sickle Cell Individual, which is going for a very cool price. So there's a stand outside by the registration desk, which you can grab a copy. And we also have a nice backdrop outside where you can take beautiful pictures, try and share. And when you share, try and also tag ISCC on their socials, and we'll be ready to collaborate with the post. Thank you so much. So let's just pray and then we end. Also, you can network. There are a lot of people, wonderful people here that you can network with. Father, we thank you for such a blessed day today. We thank you that today will not just be talks, but it will transition into sustainable actions. We pray that many life-changing moments will be marked from this gathering we had today. May these conversations go as far. May these conversations not end over here. We pray also for the leadership of ISCC, that it continues to grow, that will be here next year, the year after, until ISCC becomes the biggest thing. Help us in our health, help us as we push and advocate for sickle cell disease patients. And we pray for the sickle cell disease community, patients, caregivers, that you bring help, you bring grace, and then you help everyone. As we go home, we pray for safe travels. In Jesus' name, amen. Shall we all say amen? Thank you all for coming.
From prestigious awards to tangible impact on millions of lives, March 2021 brings back fond memories of our journey. It reminds us of when our founders, Dr. Mary Ansong and pharmacist Martha Riafe, decided to embark on a mission to dedicate their lives to the cause of sickle cell disease. This came at a very heavy price. Both founders had to resign from their professional work and commit 100% of their time to the International Sickle Cell Center, ISCC. With the support of a dedicated team that works with empathy, visionary senior consultants, and committed partners, we've made significant progress towards achieving our mission, despite countless setbacks. We have created families within our community with enduring relationships grounded in professionalism, empathy, and support. Having conducted free sickle cell screenings for over 6,000 babies, children, adolescents, and adults, we have helped many know their genotype for the first time. And yes, we've seen it all. The one scared of the needle, to the mother who could feel the prick on her child's forearm, and the brave ones. Through the support of our partners, we have been able to donate vital medical equipment and medications to over 5,000 people in 13 regions, educated over 8 million people in and outside of Ghana, sparked hope in hearts, taken some back to school, helped a warrior get her dream job, paid medical bills, and supported in many other ways. Our journey has taken us to villages, towns, and cities to uncover their sickle cell disease knowledge, attitude, and practices. The more we worked, the more we realized the numerous gaps that require urgent attention, evidenced by an influx of questions and requests for support from both within Ghana and internationally. We cannot underestimate the burden of sickle cell disease in our part of the world, and there is so much that needs to be done, so we can't stop now. We know the sweat and blood of these past 3 years are very worth it. The rain, near misses, and diverse challenges will not stop us until there's a global awareness and support for people living with sickle cell disease and sickle cell trait, as well as an accessible cure for those who need it most. We are only 3 years and full of gratitude to everyone who has supported us so far in achieving these milestones. We know that as you join us in the fight against sickle cell disease, together we will rewrite the sickle cell narrative for millions of people and build a healthy future for generations unborn. We are 3 and grateful.